Kindly come. Let's settle down. Kindly, let's settle down.
My head here. Oh, okay. We can use this.
I can use this one.
Use this. It is not on.
Okay. Can we settle down so that we are ready for the next session? Tell the HODs who are here, they can see me after this opening ceremony. They come to the registration desk after.
Yes, let's settle down. HODs from Nairobi. Nairobi HODs who are present. Once you are done with the opening ceremony, please see Madam Egla at the tent.
Thank you, Mr.
Hapo mbele.
Ndio hawa wanaingia. Ndio hawa wanaingia.
Songesha kidogo tu. Songesha kidogo. Which side?
Okay, let us be upstanding. Let's be upstanding to usher in our guests.
The anthem is the anthem. Where is it? Anthem. So we're going to have our national anthem. So I ask you to be upstanding at attention for the national anthem. Thank you. We may take our seats. Give me. Beryl. Our chief guest, we are glad to be at the 8th Scientific Conference of the Kenya Medical Training College, and would like to start with a word of prayer. I am going to invite Lucy Courier, our Deputy Registrar, Quality Assurance, to lead us in the opening prayer.
Let us believe and pray. In the name of the Father, the Son, and the Holy Spirit, amen. Our Lord and our God, with humility and thanksgiving in our hearts, we want to thank you this morning, Lord, for your goodness, for bringing us to this occasion when we are having our scientific conference. And dear Lord, this morning, we want to thank you for our Cabinet Secretary, who is the chief guest, who has come to grace this occasion. We thank you for the leadership of this country. We thank you for the leadership of the Ministry of Health. We thank you for the leadership of the KMTC as an organization, starting from the board of directors through the chairman, the CEO, the entire management, the staff, the students, and all our stakeholders. As we continue with this scientific conference, Lord, we pray that all the knowledge that is going to be shared here is going to be impactful in the health sector as we continue to improve the livelihoods of our citizens. We thank you and we praise you, for we believe and trust in the name of the Father, Son, and the Holy Spirit. Amen.
Amen, and thank you very much. So our chief guest, Waziri Honorable Aden Duale, our Director General Health, Dr. Patrick Amoth, our Chair, KMTC Board of Directors, Mr. Josiah Chariot, our Chief Executive Officer, KMTC, Dr. Kelly Olwatch, all the board directors that are present here, Professor Kimayo, our keynote speaker, all delegates or participants who are present today, our principals, our heads of departments, or our staff, and ladies and gentlemen, I want to welcome you to our scientific conference that is beginning today. It's a 3-day conference. It is international for the very first time because we have participants and presenters from other countries, including Uganda, including Malawi, including Canada, and also including the US. Thank you. And we also had additional persons presenting abstracts from other countries. There are those others who did not make it to this level. So we had quite an interest from other countries. In addition, we had a big interest from our own country, including institutions outside KMTC, as well as our hospitals, health facilities. We have our staff and also our students who will be presenting. We have a total of 47 papers presented, 36 being oral and 11 being poster. It's also the very first time we're having these poster presentations. We do our conference every 2 years, and last year we had 28 papers, and the previous year we had 24, so we can see the trajectory. We are increasing in the number of papers. Our theme is advancing health equity in a rapidly changing environment. And this morning, we began with a panel discussion, which examined exactly how is the environment changing, and also what does health equity mean in that environment. We have some sub-themes which reflect the issues of interest. For example, health professions, education being what we do is of big interest. And today we will even have a plenary discussion by Mr. Samuel Oku from NEC, discussing about CBC and how we need to prepare for the same. Another sub-theme is healthcare financing, very important, digital transformation and AI in the intersection of health and education, which is where we are. We're also looking at climate change and health, how it impacts health. Also health research in that advances health in other areas, and also health, wellness, and disease in general. So those are our sub-themes, emerging issues. The impact of this conference is that, going forward from here, it doesn't end here, because the research that have been conducted And most of them are collaborative research, collaborated by a group from different campuses and different institutions. We then go on to do policy briefs that are expected to impact the way we do things, especially in the area of making sure we have fitness for purpose in health and education. I want to mention that we have collaborators in various places, like, for example, Micro Research Canada, we are collaborating. I want to say that also people like NEC, we have been working closely with them, and therefore we are taking forward this. I thank you and I welcome you to listen to the presentations. I now want to invite our Chief Executive Officer, Dr. Kelly Oluoch, to take it from here. Thank you.
Thank you so much, Deputy Director, Academic, our CS, Honorable Dwale, our Chair of the Board, Board Directors present, our DG, Dr. Amoth, our presenters, our principals, our students, our online participants. Good morning to you. Good morning. You are not happy. Good morning. Waziri, this is perhaps one of my happiest days as the CEO. When we visited you in your office, Waziri, you promised that you'll come. And today, you've honored that promise. It really means a lot to us. Waziri, you have proved to be a listening CS. And most of the issues that we bring to you, we believe and we know that they will listen. Waziri, for that, we really, really appreciate your leadership and your ability to inspire all of us to do our very best. Waziri, let me tell you about KMTC. This institution is 98 years old. We are soon celebrating our centenary year, and that means that we'll be 100 years old, having started in 1927 with 4 students. Waziri, that growth has been phenomenal. We now have over 70,000 students. From 1 campus to 90 campuses and 6 satellite campuses, Waziri, that has only happened because of the support that we get from the government. And Waziri, since 2013 to current point, the government has supported KMTC to grow. Right now, Waziri, we have 90 campuses, 6 satellites. We have 18 campuses that are ready for uptake. And Waziri, you are aware about how we are going to do it. Waziri, we graduate over 24,000 students. This year alone, we are going to graduate that number, and we continue to grow. This year, we have admitted 34,914 students. And the demand for our courses continue to grow. And as you have advised us in the board, Waziri, we will continue to ensure that our courses are market-driven, that we are not graduating people who are going to tarmac. We are going to graduate people who will have an opportunity in the marketplace. Waziri, you have emphasized in the boardroom about the responsibility we have as leaders in this institution, that you have said through what you've just said, I will paraphrase it, that the country lacks leadership and the country lacks accountability. And the leaders are called upon to be leaders who will lead in times that are hard and good, and also be accountable. Waziri, I want to tell you that in this institution, we hold accountability very highly. Together with the guidance of the board and over 90 of our principles, Waziri, we want to promise you that there will be value for money, that there will be responsibility in the way we use public resources, Waziri. The burden of making sure that quality is offered to every program, to each student, is emphasized in this institution, and we are aware, Waziri, that we have the responsibility of giving the very best to our students, Waziri. We face a few challenges that we have briefed you about. One of the challenges we are facing is the issue of staffing. And Waziri, you have given us a way forward, and we know that we're going to do something about it. We also have a challenge of clinical areas, limited number of clinical areas because of preference to private facilities, private universities over government students, and the charging of our students who are already bearing the hardship, the financial hardship in this country. Waziri, you have given us direction, and we know that you're going to do something about it. Waziri, we have 18 campuses that have been built, ready for take-up. We don't have resources. We know that you are aware, and you're going to raise the same in other higher offices. Waziri, we also have a challenge of staffing. We have a shortage of 3,350 staff. That will cost us 6.8 billion. Waziri, you have advised us on how to go about it, and we will proceed to follow your advice, and we know that you're going to raise this with the president, and we're going to get a solution. Waziri, in today's event of research conference, Waziri, research is not a side event in KMTC. It is at the core of our strategic plan. Our key result area number 3 is on research, innovation, and consultancy. And what we are doing here is our culture. And it is necessary, Waziri, that you are here to also reinforce the need for this institution to be one that is informed by research data and is able to make informed decisions that are based factual, not rumors. Waziri, because of that, I want to recognize the organizers of this conference, the research committee. They can just stand up so that you're able to see, and we appreciate them. We can clap for them. Thank you, my seat. Waziri, as my deputy has said, we have 36 research presentations that are going to be made. 11 of them are posters. And Waziri, we continue to engage in research, and we have a scientific week in this organization, and we continue to uphold research highly in our events of activities in this institution. Waziri, finally, let me appreciate you. Your leadership within just the 2 months that you've been in office is remarkable. It is astounding. Can you help me clap for Waziri? Waziri, let me appreciate the board. The chair, through his leadership, and the board members have ensured that there is separation of power, and we work very collaboratively to make sure that this institution is moving forward. I want to appreciate the ministry staff, the PS, the CS, yourself, the directors, including our Director General, for his valuable contribution to this institution, Waziri. We also want to appreciate the research committee, the presenters, and the keynote speaker of this forum. Waziri, this institution will not move without the support of over 90 principals who are here today. Today, I want to appreciate each of them, and I want to tell them, Waziri, that they have our support all the time. Finally, beyond knowledge, this conference offers an opportunity for connection and collaboration. I wish all participants fruitful engagements, meaningful dialogue, and actionable outcomes over the next 3 days. Thank you. It is now my honor to invite the chair of the board to give his remarks.
Good morning. Bwana asifiwe. Now kwa Waislamu, this is the week. Let's also celebrate with our brothers, the Muslims. Sawa sawa. Don't be selfish principles. If you see a Muslim around, just encourage him or her that this is your week. And all will be well with them. Before I read my speech, CS, I want to assure you that at KMTC will stand behind you. From the board, management, even up to the gate, the last person in the office, the gate officer, we are working as a team. When you are working under pressure elsewhere, come to KMTC to relax. We have nutritionists here who can balance food for you. We have also psychologists who can take care of your pressure. We have an integrated team that will take care of your interest. We are working as a team. Also pass our greetings to the president that we are behind him also. We'll support you so that we move in the same direction. The cabinet secretary, again, with me, I have the board of directors. Let me ask them to stand quickly. Board of directors. Dr. Mott is included. At the far end is Hadlin Lusui. She's the chair of audit. Next is Aden. He's a member of the audit committee. Dr. Mott is in Aztec, correct? HR, yes, and audit. Thank you very much. Jeboy is the chair of Aztec. Thank you. We have Dr. Omolo is also a member of HR. Thank you very much. You can now sit. Cabinet Secretary for Health, Honorable Aten Tuale, board members present that I've introduced them to you. CEO Dr. Kelly, who is our secretary to the board activities. All speakers present, online participants, KMTC staff and students who are following our engagement, and members of the fourth state. It is a great honor to welcome each one of you to this important scientific conference of Kenya Medical Training College. Wanawasiri, karibu sana KMTC. When we came to your office and we told you that we need you like yesterday, you responded, and we are happy with that. The important gathering comes at a time when the world, and especially our health systems, is crumbling with the rapid change, emerging threats, persistent inequalities, and that is why this year's theme is advancing health equity in a rapidly changing environment. And this is timely and it is urgent. At KMTC, research and innovation are central to what we are and what we strive to become. In fact, research and innovation are key strategic resource areas in our strategic plan. We understand that without serious investment in evidence-based decision-making and application of modern technologies, our mission to deliver accessible, high-quality medical training and improve health outcomes will remain out of reach. As a board, we continue championing research as a critical pillar of our growth and relevance. Our commitment is to turn knowledge into real-world impact. That is why we have doubled our institutional support for staff and student-led research projects that the principals you are aware. To guide these efforts, Kenya Medical Training College has developed a comprehensive research and innovation policy. This framework ensures that all research activities meet ethical standards, align with national health priorities, and are supported from concept to publication and beyond. Wanawasiri, we know that transformative research cannot happen in isolation. That one we know. It processes through partnership, and that is why we have a long list of friends, including yourself. I'm pleased to inform you that KMTC continues strengthening collaboration or partnerships with leading local and international institutions, even including individuals. This includes, just to mention a few, but not conclusive, Micro Research Canada, and Neville Medical College, Northwestern University, USA. We have Cambridge, county hospitals, regional health departments, offering practical research ecosystems. Africa CTC is also included. Africa Union, where we are exploring joint efforts in mental health and emerging health threats. Recently, some staff were taken through short courses on mental health and related annexes. This partnership ensures that our research output meets global standards while remaining locally relevant and impactful. As we expand our research portfolio, we must transition viable research outcomes into tangible solutions. That is where we belong as KMTC. KMTC is actively building infrastructure needed to support commercialization. This includes developing systems for intellectual property protection, establishing innovation hubs, and strengthening industry linkages, all aim at transforming ideas into tools, products, services that address pressing health challenges. Distinguished guests, ladies and gentlemen, as we participate in upcoming discussion, let us remember that the ultimate aim of research goes beyond mere publication. It is about transforming systems, improving service delivery, and most crucially, changing lives. To our researchers, students, and partners, you are the custodians of KMTC future. The scientific conference is made even more meaningful by milestone we recently achieved. KMTC certification under the ISO 901-2015 quality systems are verified by the Kenya Bureau of Standards. The certification proves our commitment to excellence in training and delivery of services. Our support reaffirms our full support for a policy environment that nurtures and a vibrant research culture. We recognize that sound policies and governance are key to attracting partners. Together, we will not only train health workers, but also inspire innovators, empower change makers, advance health equity across the globe. With those remarks, Banawasiri, let me now take this opportunity to invite you to talk to these literate members of the society.
Let's be seated. The chairman and the board of KMTC, the CEO and the leadership and management of KMTC, distinguished delegates, good morning. It is a great honor for me to officially open the 8th Kenya Medical Training College Scientific Conference. And I wish to particularly acknowledge the leadership. My two PSS are busy on other national duty, but I want to acknowledge the chairman, Mr. Cheriot, the CEO, Dr. Kelly, and Professor Kemayo for their leadership, and the team that put together this scientific conference. And I am very happy. Majority, 90% are women, and that's why it's very successful. And to the students, faculty, partners, and online participants, and our guests, as I see you, I value you, and I thank you for being part of this very critical moment. As a Cabinet Secretary for Health, and as a member of the KMTC fraternity, I feel right at home. KMTC has been the engine room of the Kenyan frontline health care workforce, its products, our nurses, our clinical officers, our lab technologists, and public health officers are not just practitioners. You are part of the backbone of our health system. You are the ones who bring universal health care coverage to life. This conference speaks to the heartbeat of our reforms that is taking place in our country within the parameter of the healthcare. The theme, advancing health equity in a rapidly changing environment, is not just an aspirational. It is the very grounded, the very ground we stand on. Our health sector is undergoing a one-in-a-generational transformation under President William Ruto's bottom-up economic transformation agenda. Universal health coverage is no longer a dream. It's a plan. It is funded by government, and it's already being implemented. And for your information, yesterday at 10 p.m., we recorded the highest number of Kenyans who registered with the Social Health Authority for the first time. And the number was 74,000. 74,000 Kenyans registered. Majority of them are now ready to access our primary health care facilities, level 2 to level 4. All they need to, both public, private, and faith-based. All they need to do is to register, they walk in, they are received, they are treated, they are given drugs, and they walk out. So KMTC is not just along for the ride. It is steering the wheel from assisting in training over 107,000 community health promoters to anchoring primary healthcare services in all our 47 counties. KMTC remains central to the delivery of our healthcare dream. It's the central to the delivery of our affordable, accessible, and dignified care to every Kenyan, regardless of their income or location. I have had a very candid conversation with the college leadership on the challenges you face, particularly on student financing. And I want to assure you that we are actively engaging with the National Treasury to unlock the 500 billion through the help to support the KMTC students. If I leave here today, I will not give time to my brother, the Minister for Finance. And the Minister for Finance has a very good relationship with me, because at one time he was the minority leader and I was the majority leader. God is great. We found ourselves in government. So we have a very good chemistry. And I'll tell him to release the 500 million, which is in the budget for our students to access. We are working with the Ministry of Education to ensure that KMTC is treated equally within the universities and TVET institutions when it comes to help access. No KMTC student will be left behind. And I've already made a written communication to my colleague, the Minister for Education. In our country, there will be equity, regardless of where you come from, regardless of your religion, and regardless of the community you belong to. Even as we work to open up financing opportunities, I want to challenge KMTC to be innovative. You must think beyond government capitation. You must explore aluminum endowments, philanthropic partnership, and you must blend financing models. If you want to remain at the top, you must also lead in sustainability. Let me speak frankly about the growing concern, the unchecked expansion of health-related courses in this country. And I want the principals who are here to listen to me. Some institutions are churning out graduates with little regard for quality, relevance, or employment pathways. And I want to be very clear today that the Ministry of Health will not sit back and watch KMTC become part of this problem. KMTC will not offer credentials without competence. And I'm putting training institutions, particularly in the health sector, and our regulators on notice. Every course must meet a really public health need in our country. Public health need is critical. Every graduate must be ready to serve in our country. This college must continue to set the golden standard, not just in numbers, but in quality. That means rigorous curriculum review, strict admission criteria, monitored clinical rotations, and outcome-driven teaching. You are the national benchmark, KMTC, and you must stay there. Everybody else, you are 98 years old, so you must stay there, and you must be the national benchmark for the others to follow you. Research must drive our progress. In a world of pandemics, the NCDs, the digital disruptions, and the climate-linked disease outbreaks, we cannot afford to operate on a guesswork. Let me be very clear. In our ministry, policy must be backed by data. I applaud and appreciate KMTC for integrating research into its DNA. And I encourage every student and faculty member here to see research not as a thesis requirement, but as a public health obligation. I am particularly encouraged by the range of topics on your agenda: competence-based education, artificial insemination, AI, and digital health, climate and disease, healthcare financing, and NCDs. These are not just academic luxuries. They are Kenyans' real-world priorities. Push the boundaries, question everything, and come out with the practical implementable recommendations that we can plug in straight into the policy pipeline. I look forward to receiving a formal brief of your outcomes at the end of this conference. Let me assure you, your ideas won't gather dust on our shelf. We are building a government that listens to evidence and acts on it. Your voice matters. In closing, let me remind you that science without action is charity. Let this not be a conference of very good speeches and great PowerPoints. Let it be a turning point. Let it be called to action. KMTC must continue to produce not just graduates, but guardians of public health. You must produce very good caregivers and compassionate people. And that is the legacy we must protect as KMTC. One of the things that the leadership, the board, and the management told me about is the clinical services, the rotations, which our students are charged when they visit public hospitals. That will never happen, particularly I will start with the level 6 that are under my ministry. Kenyatta Hospital, Kenyatta University Teaching and Referral Hospital, Mathare National Research Hospital, MTRH, and the professor is here. You better tell them that message. The spinal injury. I have told the DGA and the SA, when we go back, we will communicate to them. They will stop that. And because this evening we are meeting the Council of Governors with the President, I'll whisper the president to pass the message to the governors. Even we looked at the list, even the payments are not harmonized. One is charging 10,000, one is charging, my county is charging Garissa 1,000. Another one is charging 2,000. You know, there's a problem in our country. Even if there was charging, there should be a standard. There must be evidence. There must be, you know, a very good reason. But Kenyatta Hospital here, where I was yesterday, is charging 10,000. And I thought, the students are coming to help you. It's like an entitlement. So because health is devolved, I'll consult with the Council of Governors. But for my level 6, I think the powers I have. Yeah. The powers I have. And we must bring, I want you to help me. We must bring trust, hope, and order to the health sector. That is what I want to do. I have no other business. And I want to thank the leadership. When I walked in, I remembered when I was a minister for defense for 2 years, the best places for you to visit, which are neat and clean, are our military barracks. So when I walked in, I said, have I come to DOD? Thank you, Chairman, Board, and the CEO. You know, well-taken grass, clean pavements, and that is the first impression you get, that there's a leadership, there's a good leadership in that place. Can we clap for Dr. Kelly and his team? And finally, let me talk about UHC, Universal Health Coverage. Universal Health Coverage, I have been around. I had the opportunity to serve with the late President Kibaki when he was the MP for Odaya. With great leaders, very, very good leaders, I had the opportunity. He tried universal health coverage. The Honorable Charity Ngilu was the Minister for Health. And there was a bill called Ngilu Bill. And Parliament, then I was a member of Parliament, we passed it. But President Kibaki refused to sign. Not bad, he was a good man. He said, how are we going to finance universal health care? And the Minister for Finance was David Miraria, so the bill could not pass the cabinet. President Uhuru came and tried his best and started with the 4 counties, Kisumu, Nyeri, Isiolo, and Machakos. And sometimes in 2017, he called a meeting where I was and he said, this thing can't work. He dropped the ball. Then comes the hustler, President Ruto. And you know, in leadership, and I tell DG and the colleagues in Ministry of Health, until this morning, I was telling the DG. I was telling the DG this morning, on a DG, my business in this ministry from morning to evening is to bring solution and solve problems. So tell your people not to take me back. We must move forward. In leadership, you must make the right decision, not popular decisions. Before the 74,000, 23 million Kenyans have registered for SHA. The former NHIF had only 9 million. only 20% of the population, which were salaried people only. The other 80% of our population had no insurance cover. Either they were being helped through fundraising, WhatsApp fundraising, or majority were dying at home because they could not finance. In 2023 alone, out-of-pocket health finance, the country spent 153 billion shillings. Today, God is great. A Kenyan can walk to any of our level 2 to level 4 as long as he is registered, and he will be treated. And we have increased the funding for KEMSA to increase their refill rate to 100%, so that in the most remote parts of our country, the health centers have drugs. And KEMSA will not be paid by anybody. They will be paid by SHA, Social Health Authority. We have brought a digital system where we can know from the facility who is treating. If a surgery is done, we will know that doctor. Without his pre-authorization code, that surgery will not be paid. So the system, we are getting rid out of ghost facilities, ghost healthcare workers, and fake and counterfeit drugs. Because even in the system, we have track and trace. We can trace the drug that is. This must be the NHIF cartels. Yeah, you know, they are. Verification committee. So that I pay them. Those who are the right bills. I don't have. So I told them I don't have a bill. When they came to me, I told them, go talk to them, you remove the case. Because I really want to be part of this fraternity. I'm going to help KMTC. We have serious expansion. We need more staff. We need more infrastructure. I'm sure the principals are facing a lot of challenges. We will stand with you because you are the most important. And finally, I have told the CEO that we must invest in the training of our very critical, more specialized nurses and clinicians. You know, these people are saying they want to take our nurses. They are coming for our best of our best. They want the theater nurse. They want the ICU nurse. So what happened to our facilities? Also asked to train new ones. We replace them. Am I right? So I want all our colleges. Those many remarks. I really want to thank you and for inviting me to this very, very important conference.
So as we come to the close of the opening ceremony, I want to invite the chair of the Principals Forum to give a vote of thanks. Then we will request one of the principals from Karisa to close with a word of prayer. Then we will go out and take some photo sessions. Principals Forum Chair, Karibu.
Thank you, Madam Didi. Our chief guest of today, CS Adentwale, and the entire leadership of the ministry, the board of directors chair, Sarah Jose Cheriot, and the entire leadership of the boards of directors, our CEO, Dr. Kelly Olwach, and the entire leadership of the KMTC, principals present, lecturers and students. Good morning. Our chief guest, thank you so much for gracing this occasion. We really appreciate you've given us words of encouragement, and our CS chief guest today, hope, trust, and confidence has come to KMTC. Your words here, CS, we feel like, oh, how we wish you would have come earlier to this ministry. CS, we shall follow your call. We shall rally behind you so that we bring solutions to the issues that are affecting us, even right at the campuses. We really appreciate that. And we like your stand, we like your boldness, we like your decision-making skills. We really appreciate that. And when you go back, send our regards to His Excellency. We really thank him for appointing you to be in that office so that you lead in the front and solve the issues that are bedeviling our ministry. We know with you, many issues will be solved. Many issues will be solved. Even the issues that you've said, all of them will be solved. Even prioritization of employment so that our graduates can get employment in the counties. I know those ones will be done. So with those remarks, I really appreciate you and may God bless you. So now I invite Principal Karisa to, yes, she's here, to come and close with a word of prayer. Can we appreciate every one of us? Thank you so much.
Our chief guest, Cabinet Secretary Honorable Duale, Chairman of the Board of Directors, our CEO, and all protocols observed. My name is Habiba, Principal Garissa Kenya Medical Training College, and I request all of you, we stand up for the prayer. Bismillahirrahmanirrahim. In the name of Allah, the most gracious, the most merciful, as we conclude this gathering, we turn to you, O Allah, with hearts full of gratitude. We thank you for bringing us to purpose and collaboration. We especially thank you to bless our guest, our chief guest, Honorable Duale, and other dignitaries We reward them with good for the good work they are doing, which is beneficial to others, to our communities, and the inspires they give, the positive inspiration they give to others, increase them in wisdom, sincerity, and strength, and make their effort a lasting legacy of goodness. O Allah, bless all who are present in this meeting today, strengthen our unity, purify our intentions, and guide us to act justly with compassion with all that we do. Indeed, Allah is with those who fear him and those who are doers of good. God bless Kenya. God bless Kenya Medical Training College. Amen.
Yeah, thank you, Principal. We can sit down as we allow our guests to move out for a photo session. And the photo session will be led by the communications manager. Okay, let's go.
Thank you. So we have a list, we have some photos. I'm going to say we have a photo for, of course, the team that has left. Then after that, we'll have additional managers. And we'll have a photo for the organizing committee, so please be there. Then we'll have a photo for principals. We have three photos of principals. So we'll ask, we come in batches of three groups so that we fit in. So I'll call you just a
Hello, hello, hello. Yes, let's take the next 15 minutes to have a cup of tea. It is served from the tents behind. We will return left at the end of the foyer. There are tents out there. Tea is ready. Let's have a tea and be back in the next 15 minutes.
Go straight to-
Okay, thank you for taking your seats. We want to go to the keynote address. So we are really getting ready for it. The presentation will soon be up. And therefore, what I'm going to do, I'm going to invite the chair of the team that has been organizing that team to make a few remarks on the process of organizing and maybe introduce the team. Dr. Aswani has been our chair. Thank you.
Thank you, Madam Didier. Our keynote speaker, chair of the board, CEO. I think it's and all senior management, delegates, good morning. Yes, on behalf of the organizing committee, it's my pleasure to receive you, I think, for this session, which is the keynote, the centerpiece of any conference. This is a process that we've been involved in for quite a while, coming through with thinking about the theme and sub-themes, which then form the basis of what is discussed. As a committee, we are very much aware about issues that are dear to government in terms of UHC and its relevance to and intent to bring equity. And that's why we chose the theme that we did. At the same time, we are acutely aware that KMTC's core mandate is to contribute towards manpower. And so you note, therefore, that one of the key sub-themes that we came up with has to do with health professionals' education. But equally, we are aware that financing underlies all aspects of the healthcare. And so we also have lined up a plenary presentation in relation to that. But this morning we already had a plenary discussion that was centered on the theme, where we had very good presentations and discussions in terms of what constitutes equity, what are the enablers, what are the barriers. And so I'm sure the delegates are very well empowered in terms of what is going on within the country. In coming up with this theme and sub-themes, I think we are a team, the organizing committee, and I will just want the members who are present to stand so that I can introduce them to the delegates present. Yes, I've been called the chair, but actually, mtu wa mkono. The chair of the organizing committee is our able DDA, Dr. Nyaira Mwangi. And so I stand in when she's not around. I steer the ship, and then whatever we come up with, we discuss with her, and she gives us guidance and concurrence. Thank you for your steering. The secretariat to the committee is headed by the Deputy Registrar, Research, Ms. Gigan. The other members next to her is Marcela Ogendo. Then we have Lucy Kuria, Principal. We have Dr. Manyara Lucy, Dr. B, and Dr. Wagaki Kisheru. Thank you. Oh yes, at the back with Matthew Kipturgo. That is the team that has been working on this. And so we are so very, very grateful for the support we've received from the CEO and the college administration at large to be able to reach where we have reached now. So in the context of our time constraints, so led by Indiana University. Professor Kimayo is also a professor of internal medicine at Moi University and a consultant and physician at MTRH. His passion for medicine began while volunteering for the Red Cross from 1977 to 1978 and staffing a school dispensary in Turkana County in 1979. He realized that making a difference in people's lives by caring for them and helping his community lead healthy lives is very fulfilling. This nudged him to enroll for medical school the following year. He graduated from medical school at the University of Nairobi in 1985 and became Moi University School of Medicine's first internal medicine lecturer in 1995. Professor Kimayo traveled to Indiana University in 2000 for a 2-year fellowship in clinical pharmacology. And while at Indiana University, Professor Kimayo had the opportunity to learn from Dr. Joe Witt, who was a leader in HIV care and who also provided funds to treat the first Kenyan patients living with HIV. When he returned to Kenya, Professor Kimayo became the Kenyan leader of the growing AMPATH HIV care and control effort. Some of the patients who had been expected to succumb to HIV while he was in the US instead became the first patients to receive antiretroviral therapy and made miraculous recoveries. Professor Kimayo has been involved in all aspects of the AMPATH partnership for more than 22 years. AMPATH HIV programs currently provide care for more than 120,000 people living with HIV in 9 counties in Western Kenya, and the AMPATH Center at MTRH, which he leads, is one of the first and largest single HIV clinics in Africa. Additionally, the foundation created the HIV program But the foundation created by the HIV program is now being used to build comprehensive model of population health, inclusive of care for chronic diseases and the availability of universal health insurance. Professor Kimayo is a leader in efforts to create sustainable health systems at the county level throughout Western Kenya. Professor Kimayo believes that part of the job description of the empath physician, regardless of their other roles, is to see patients. The desire to help his community that led him to enroll in medical school has led to a life and career of helping people in underserved communities across Kenya and around the world. So that is the academician who is going to speak to us this morning. Welcome, Professor Kimayo.
Thank you very much. I feel quite honored actually to come to give this keynote speech, and the team that asked me to come. Thank you, Dr. Nyawira, for receiving me this morning and make me feel at home, and also meet the VIPs who are seated here. You know, it feels, I will just make a very quick run through because this morning, most of the things, a number of things that I was going to say have already been said, but I'll say it in a different way. And the topic, let's go on. This is what I was given as the conference theme, and I actually took it the way it is. I didn't modify it. Advancing health equity in rapidly changing environment. Next. So this is my outline. I'll just give a little more personal touch and introduce what health equity is. It was already discussed this morning, and I watched it from Dr. Nyawira's office. I'll give something about AMPATH, about PEPFAR, and then the key message I would like to give is the equity effect of universal healthcare. That's where it touches. And then give just a sneak preview of how UHC is being done in Nigeria, Ghana, and Mexico, and finish with how it's being done in Canada and France. So, next. Forward, please, next. That's the Eldoret city where I come from. I just wanted to show those who haven't been to the youngest city. Next. That is Lodwar Secondary School, where I did my secondary school. It still looks the same. This is, next. This is St. Patrick's High School, Iten, where I did my A-level. You can see the runners there. Next. This is me in second year with my colleagues. Look for the tallest, with full hair. Not like the hair I have now, with full hair. Next. Of course, I've been recognized as an Order of the Grand Warrior of Kenya for the work we are doing. And that is what I wear sometimes. Next. Thank you. So, this has already been done. I'll just do it differently. Introduction to health equity. Next. I just pulled this, but I removed the photo. And it reads, if I get sick as a member of parliament, I must be taken to Nairobi Hospital. That is for my class. We may build good county hospitals and make them good, but that's not for me. Mine is Nairobi Hospital or abroad. And it also goes on to say, regarding Susan Kiiga's decision to give birth abroad, she could afford it, and it's allowable. It's allowed. Next. This is one registered hospital in Northeastern. It is actually registered by SHA, and it has 30 beds. Next. So I put those pictures just to introduce you what is not health equity. And health equity means full health potential regardless of social, economic, gender, or environmental circumstances. Next. So next. So how do we address this? There are things we call social determinants of health. They include affordable housing, nutritious food, quality education, employment opportunities. Next. Culturally and linguistically appropriate health information. Next. Others also include engaging communities, data-driven decision-making, collaborating across sectors, healthcare, public health. These are things that were discussed this morning. And I'm just restating them. We must address them. In fact, those first few I mentioned, affordable housing, good education, you hear it, nutrition, you hear it everywhere. You hear it across. And the CS said them very well. So in order to get health equity, we must address all those, including employment, which I had been mentioned this morning. Something I struggle with every day because I have people coming to look for jobs in my office. Next. So just to mention about AMPAT very briefly, that's an acronym. 2001 is when we treated our first patient, and we first called it the Academic Model for the Prevention and Treatment of HIV/AIDS, AMPAT. But in 2008, we realized we can't just live on HIV. So we changed the name to AMPAT, and it is Academic Model Providing Access to Healthcare. Next. You know, I just wanted to show this picture, that there are people in this audience, senior, who came to visit us and benchmark. So they are my witness of what I'm going to say. And this is the KMTC, of course, had a very big program funded by USAID called UMI, which unfortunately Trump did. Next. I'll not go into the details. That's the detail of AMPAT, what we plan to do. And in it is UHC. It's supporting the population that are suffering the most, the poorest. And we designed this in 2001. And we're still going. Next. This is a team of all USAID-funded partners in 2006 at AMPAT Center in Eldoret, where the team here visited. Next. And this is, our radiotherapy equipment is still working. This is Chandaria at Moi Teaching and Referral Hospital, where we treat cancer and other chronic diseases. And standing there is my mentor, Professor Mamlin, then CEO of NHIF, and our CEO then, and myself. We actually got this building done after a flight to Kimanjo in northern Nanyuki, where we were supporting one of the celebrities develop a hospital in Kimanjo, the AMPAT way. On the way back, he said, "Do you have any needs?" We said, "Yes, we have designed a chronic disease building. We don't have the money." "How much?" And we said, $4,000. She wrote a check, and that's how the building came in. Next. This is MTRH. Next. So what is AMPAT? We formed AMPAT as a platform to look for funding from outside the university, outside the hospital, and outside government, including PEPFAR in 2001. Next. And these are the underpinnings or the strength of AMPAT. It's academic partnership that have been stated, electronic database. So we capture all the data of our patients electronically and easy to get research from it. Institutional and government of Kenya support on financial management system, one central nervous system, and what I call tyranny of numbers. If you have big numbers, it's easy to create data and be a voice. Next. These were the challenges. They included space, staff, testing, ARVs. Then in 2002, I was like, God, I chaired a committee that's decided who gets ARVs and who doesn't, because we had very few. So we decided who dies and who lives. And unfortunately, you know, I had 1,000 patients on lineup for ARVs. I got donations for 5. So I selected with a team which 5. And of course, we had exit and sustainability plans from the get-go. Next. And the other challenges are the ones you all know: public procurement, taxes, licenses, journey to self-reliance. Next. This is in Chulaimbo. We were starting the first clinic in Chulaimbo in Kisumu County, Kisumu West. The year is 2004. And next, just go through. That's how we started. One, then several, then touched the entire Western Kenya. But this is very important. Our medical school at Moi is called problem-based learning and student-centered, with students going to the field from first year, called COBS sites. And this is community-based education and service. It's a unique, not a lecture system like the school I went to at the University of Nairobi. And therefore you train students very, very early, like Dr. Oluga. And well, I taught Patrick Amott somewhere else. But you know, those are the kind of students we produce. And you can see the effect. And this is what we touch in Western Kenya next. And of course, the handshake didn't just start here. This is 2008, and we are doing a handshake to do door-to-door testing in Western Kenya together with our partners. And our guest of honor was the former Prime Minister. And then the Minister, Professor Nyong'o, Minister for Health. And next. And this is my friend in Trans Nzoia, His Excellency Natembea. And we were launching UHC in Trans Nzoia. And it is moving on. And with the next, and this is with the Kisumu governor, Professor Nyong'o, doing an activity in Kisumu County. Next. This is in Uasin Gishu County, again, about the other innovations using drones, and also opening a mother-baby hospital in Uasin Gishu. Next. This is a slide we made in 2009. It's about UHC. It's about making the Ministry of Health and supporting the Ministry of Health and all the pillars that we did then. So why I'm showing these slides of AMPAT is we are also a UHC implementer. And we ran a very successful UHC program in Bunyala, in Busia County, in Budalangi. And we have kept trying this, and worked very closely with the then NHIF. Some things we failed, some things we succeeded. Next. Just to inform you that AMPAT has gone global. So we have AMPAT Nepal, AMPAT Mexico, AMPAT Ghana, and then ours is now AMPAT Kenya. So we do the same model in those 4 countries, and we work with several North Americans on this. Next. PEPFAR. Next. This is when PEPFAR was being signed in 2003, December, by President George W. Bush. Next. And then Trump comes in. And of course, they changed the policy and all programs were stopped on the 20th of January 2025. And it was just like that, just stop. Next. Of course, the details has been captured in this government document, but there are so many other ways of looking at the problems that we developed when that was stopped. And that is health equity, but touched. Next. So what happened when this funding was stopped? I know KMTC stopped. We also stopped, but we didn't quite stop. In another 2 weeks, we were up. So what happened? Disruption of programs, drug shortages, sample collection, transportation was disturbed, weakening reproductive health services. Look at the last one, hatred and insecurity. Next. So look at what happened. So we had a conference with the NASCOP director, integration conference in Mombasa. The following day, the Star newspaper captured it on the headline, team formed to close HIV clinics in Kenya. So I called Dr. Rose Wafula and said, did you really mean that? And she said, I was misquoted. That's not what we discussed in Mombasa. So she immediately got the Star newspaper to rewrite the heading. And the headline was, team formed to add services in HIV clinics. And that's what we are doing. Just completely messed up everything. You have to be careful how you speak. Otherwise you can be misquoted. Next. So here is the sad news. Most of our research programs are funded by the National Institute of Health. Last week, 39 of our 44 grants were stopped in research. So we had a problem in care. Now we have a problem in research. Everything stopped. And it is any of those where Moi University was a sub was stopped. Next. And the changing funding landscape, I think I'm preaching to the choir. But look, USAID Kenya, as of January, had 110 projects. They were all terminated. 11 survived. 11 survived. And of the 11, 3 are from AMPAT. So I have USAID AMPAT Uzima, I have USAID Dumisha Afya in Bungoma, and Busia, I have USAID for the Child headquartered in Kisumu. I have no idea how they decided to stop this, start this one. But I think when you have a program with deep roots, it's very difficult to uproot. But I don't know whether they used AI. It was not artificial intelligence, it was artificial intelligence. I don't know what they used to get this thing done. But we survived, we're still going on. They have stopped our family planning. They stopped our pre-exposure prophylaxis. And they stopped our DREAMS program in Kisumu, and they also stopped our gender-based violence. But we are happy, we are going on. We just got, 2 days ago before I came, our advance for June and July. But we don't know what is going to happen next because PEPFAR authorization ends in September. Our grant ends in 2026. We don't know, but you have to be positive. You have things in there and plan what to do next. Next. Again, this is about health financing. I just want to point that Kenya is 6 to 8% of the national budget. The Abuja says 15. We still have work to do. And out of pocket, 30 to 40% next. This is what we also do. We do farming, we do income generation, we get funding from World Food Program and others, and we have a good harvest across our farmers and our patients across Western Kenya. Next. We have a lot of opportunities based on this. Next. This is a slide I put here. If you want to end a program like PEFA, there are steps to use. You need to look at leadership. You need to look at financing, at programming, and service delivery. Plan how. The health system strengthening that was formed and run by KMTC on HRH was planning for that, but it was terminated too early. The AMREF program that was doing governance was also doing, or the one from Kenyatta University that was doing finance. Those were preparations like this, but they just got terminated quickly. Next. The last one there, aligning programs. That's one of the things you need to do in preparation for closing a PEFA, or what happened when PEFA was closed in South Africa, Namibia, and when Bill Gates closed a program in Asia. These plans, but ours was not. Is that health equity? We will see. Next. UHC. Again, I'll not spend a lot of time on UHC because it has been done and it was discussed. Next. But this is what you all know. The Vita healthcare priorities. Adequate human resource, effective supply chain, health financing, integrated health information system, primary health care, community health. So this is really, it's very well thought. I'm not a politician, but it's very well thought. Very well thought. Next. And again, looking at that in more detail, and the 4 Health Act, it really should help us, should take us where we want to go. Next. Again, this is about UHC. I'll not go through that. It has been discussed. Next. So UHC was first discussed and designed in 1978. And in our 2010 Constitution, we put everything that we said about health equity. And in 2018, the CS spoke about that past 4 counties that were pilot. Next. And this is really the message I wanted to give, is the equity effect of universal health care. It's a human right. But who pays? Who has ownership? Or who governs? Next. This is from the World Health point of view, how to approach UHC. Which experts here I know about it, but I just put it here for you to see. Everything in terms of policy is there. So what is failing us? Next. Next, just flip through those ones. Yeah, it is just the WHO pillars. And next, just go through those because I know people want to go for lunch. Everything is captured in Vision 2030. Kenya has such wonderful policies. Some countries just come to borrow and go and implement. But we really work very hard when it comes to policies. They are all there. Next. So here is a review article you can read for yourself. And some of you know the authors here. It is the missing link in Kenya's universal healthcare experiment. and led by Lisa Owino, and those are the other team members. This paper has really treated it so nicely. What gives us problems? Why can't we get health equity? It's really treated here very well. Next. Look at next. So this is Nigeria. Again, I'll not go into the detail. I have about 5 slides to go. Nigeria has done poorly. They have a lot of money. They are mixing up things in there. They don't have a good UHC. And it's detailed here. Next. This is Ghana, one of the best. And I have visited. They have everything. Everybody has insurance. The processes are nice. Everything is as per policy. And in terms of, as you see there, revenue raising, pooling, purchasing, provision of care, and how it links to what the CS spoke this morning, everything in one system, not silo system. And Ghana's system is working. The only thing we are trying to work with them is you have everything, but when you go to the pharmacy, you don't get drugs. So we have sold to them what we call the revolving fund pharmacy to try, which we have it in Tulaimbo, we have it in Dale, and it works, but Ghana's one works. That's the one. Next. And Canada and France, US, I can tell you, the worst. It is one of the most unequal of wealthy societies. It's the most expensive place to get treatment. I occasionally get patients fly to Kenya for treatment because the system there have challenges. If you are rich, you are okay. So even the developed countries have issues, okay? The Canada one is better. The France one is one of the best. Australia is crashing. I mean, so we have examples to look at. Next. I put this. I didn't know that the CS going to be the guest of honor, but see what I have put here. And the reason now, this is yesterday in KNH, and what he said, I can tell you our faith in that arrangement. I hope we can get solutions. As I think if we get it, based on what we have learned in AMPAT, if this steam continues like that, and one thing I wish to say here is that KMTC have the biggest opportunity for health equity. You are in 90 campuses. You are all over the country. You are in Lodwar. You are where? And as Dr. Amoth, the DG, said this morning when we were there, he said that when they were visiting with the CS in KNH, he said, I can remove my suit and go to work, but I cannot work without a nurse. Yeah. So this is saying, I am just giving you the message. I have hope. I hope we continue like that and get things going next. And that's my last slide. And here I've said, together, everyone achieves more. Thank you very much for listening to me.
Thank you very much, Professor Sylvester Kimayo. On behalf of the KMTC Board of Directors, KMTC management, KMTC staff, students, and the entire college fraternity, we want to extend a hand of gratitude, Professor Sylvester Kimayo. Thank you so much. We truly appreciate honoring the college by your presence and coming to share with us your words of wisdom and breaking down health equity in this time and age. Professor Kimayo is indeed a giant in healthcare. Many of us grew up as we learned, as we studied, we read about Professor Kimayo, and we feel deeply honored to be in the same room, listening to the words of breaking down health equity and how it can advance healthcare. We are privileged, and as we continue with this conference, as we continue delving deeper into this discussion, we are going to converse, we are going to question, we are going to review, we are going to reflect, and we are going to look into your words, and we are going to think about the challenge that we experience, the challenges that we have overcome, and we are very proud to be here, led by our wonderful Professor Sylvester Kimayo. Thank you very much, sir.
Thank you very much, Professor. Thank you, team. Let's give a better clap. Thank you. I also thank you for your patience throughout this session. So what we'll do now, we're going to have a health break where you're about to have a cup of tea and also have lunch, and then we shall come back. So for the our chair, our CEO, board directors, we have that in the boardroom. And then for our participants here, we have it just behind here. So what time do we come back? The hour's time, what time now is it now? 12:30, so we come 1:30. So please come back 1:30 so that we continue with the rest of the sessions. Thank you very much. So our chair and our CEO and our keynote speaker and our directors, we could exit now. Thank you. The members of management, please accompany them, accompany the board directors. Thank you. Okay. Okay. Principals, officials of the Principals Forum, kindly come to the front and meet the chair just before you exit. Thank you, thank you, thank you.
Thank you. Ishakuwa.
Good afternoon. Yes, my apologies once again because of the element of disruption in our program, but very soon we'll get it back on track. As per program, we began with our panel discussion in the morning. We managed to do the opening ceremony and receive the keynote address, which previously had been planned for later in the afternoon. And so because of the arrangements that have to be made before lunch is ready, we think it is better in the interim we carry on with the program. So that possibly if we can do the second session, which is the plenary, and then we get proper presentations, we see whether by 3 we can finish that, and I believe lunch should be ready by then. And so I'm waiting for the chair of the next session, which is the plenary presentation in the area of health professions, education, with a specific focus on preparing for the future. There have been changes within the education system which require that we start thinking of what we shall be doing within the next few years. And so I would invite the chair for the session, Dr. Marcela Ogendo, to lead us through that plenary presentation. Welcome.
Thank you. Thank you very much, Dr. Swan. Good afternoon. Good afternoon once more. My name is Dr. Marcela Ogendo, and I'll be the chair of the current session. That is the plenary session 1. And the sub-theme is health professions education. As we begin this discussion, maybe we need to delve a little before we invite our plenary speaker. And maybe it's a good point to reflect once more on really health professions education. And health professions education is the preparation of health professionals. Preparation of the health workforce for their roles. We cannot talk about health professions education without thinking about the pillars of the health systems. Out of the 6 pillars, that is leadership and governance, service delivery, health systems financing, health workforce, medical products, vaccines and technologies, and the health information systems, the health workforce stands as the center pillar. And there is no health workforce without health professions education. As we think about health professions education, we are taken aback to think about the history of health professions education. The earliest trainings happened through apprenticeship. We did not really have an institution that offered medical training. And did you know that in the early 19th century, even the Royal College of Physicians, which is more or less the gold standard, only required physicians to be trained for 1 year? Did you also know that that training happened without a curriculum? Did you know that health professions education has undergone an evolution. From the time when we began health professions education as we know it, thinking about the father of medicine, that is Hippocrates, as we reflect upon his oath that we have to this day, do no harm to patients. We think again, and we think about the philosopher Aristotle. What did he think about health professions education? And he viewed it from the point of an art. And he looks at medicine as an art that aims at health. And he also reminds us that political wisdom rules over every art. And so if you're going to look at health professions education as an art, then we have to think about the various facets that affect this art. What is the political environment? What are the economics of health professions education? How does it impact the future of any civilization and any society? How do we go forward with the challenges we are facing, with the newness that we have? How do we train people differently? How do we address the challenges that we encounter on a day-to-day basis? Who are the players? This is a game with many players. Who are they and what are their interests? What are they concerned about? And as a leader in health professions education, Kenya Medical Training College must ask itself the hard questions surrounding health professions education. We have emerging issues. The blessing and the challenge of artificial intelligence. We have discussions around the viability of training and education as we have known it. Are we going to continue the same way? Are we going to have the traditional lecture method? Is it going to survive? Are we going to use the curricula that we have always used over the years? In Kenya today, the discourse is on competency-based education. At KMTC, we say we began earlier. What must we do differently to survive? Who are we going to bring in to the health professions education? And how are you going to empower them for the next generation of challenges? So as we continue with this discussion, we hope that this sub-theme is going to give us a chance to look at some of these issues. And to begin us off, we have our plenary speaker from Kenya National Examinations Council, Mr. Samuel Ouko, who will lead a session entitled Competency-Based Assessment and its Potential Impact on Health Professions Training. Mr. Ouko has over 15 years of experience in the education sector and specifically on assessment. He is a principal officer in charge of research and quality assurance at the Kenya National Examinations Council, and he has played a key role in developing of the competency-based assessment framework and currently guides assessment practices in basic and teacher education in Kenya. We are very honored to have him spare his time to be with us here to lead us through discussion. Kindly join me in welcoming Mr. Samuel Ouko to lead us through this session. Karibu sana.
Thank you so much, Daktari, to the conveners of this meeting. I want to start by saying thank you for inviting me to come and speak to these great people. I feel honored and humbled to be standing in front of you. As you have been told, my name is Ouko. I know I feel like I've been hearing the introductions here and what is going on. It makes me feel like I'm in a wrong place because people are talking medical terms. People are doctors, right? Things are medical, the medical language, right? But I feel consoled because the other day I have a boy in Form 3. Initially, when he was in Form 1, he said he wanted to work in space. He wanted to work with NASA. Those who know science, NASA, the spacecraft, right? That's what he wanted to, where he wants to work. But along the way, he changed and told me now, I've changed my mind. I want to be an aeronautical engineer. Then this year, when he came back at the end of term 1, he changed his mind. Now he told me, I want to be a doctor. So at least without my influence, right? He has been moving up and down. Now he has told me that he has settled to become a what? A doctor. And I was asking him, you know what it takes to become a doctor? He told me, Daddy, I know what it takes. Then let me see what you have in your subjects. Nikaangalia nikasema, okay, then you're working towards the right direction. So if that's what you want to be, so we pray that God help you achieve your dreams. So at least I hope there will be a time when I will feel really at home, right? So for now, I want to ask you not to look at my presentations in terms of medical jargons. I'm an educationist, right? You have been told that I'm an educationist, actually a teacher by profession. Before I joined NEC, I taught for 11 years. So I also wanted to correct that I'm not the one in charge of quality assurance at NEC. We have the head known as Mr. Andrew Otieno. I'm a member of that particular department. So what my presentation is, I'm going to look at the assessment and what are we doing as NEC. So from what we are doing as NEC, we'll be able to pick as a professional body, you'll be able to pick and see what is it that can work for us or for you. So that is the kind of trajectory that I'm going to take. So that just going to talk about what we are doing, because this is now what the actual thing that is happening at the Kenya National Examination Council. You can move to the next slide. So I want to start by taking us to making us understand where we are coming from with this thing we are referring to as the competency-based education. There were 3 major C's that we intend, or the government intends to achieve by implementing the competency-based education. So one of the problems that was realized, introduction of the competency-based education, was the disconnect between the school content and the world of work. We all live in this country, right? And we all appreciate that it is true there is there's a disconnect between the school content and the world of work. And therefore, to cure this particular problem, the government came in with what we are now referring to as the introduction of competencies, where we are looking at a scenario where we want to make our learners to acquire again the competencies as they go through education system, so that they are able to thrive in the rapidly changing world. The key word there is thrive, not to survive. We want to make the learners to thrive and not to survive. So that is what the first problem that the competency-based education is planning, intending to solve. The second slide, the next slide. The second problem was the disconnect between realizing national goals of education, which emphasizes on core values. Even if I don't look at the rest, the key term there is core values. From the during the morning presentation, nilisikia a lot of talks about professionals in this medical field. One of the presenters talked of maybe drugs disappearing from the what? From the stores. It means that there is a problem somewhere. And one of the major problems that we have, even as we, the educationists, and you, those who are in the professional health profession, is the lack of character, good character. So this disconnect between the values, national goals of education, specifically values, and the character. And therefore, this particular new education system is intending to develop a learner or a student who has good character. And how are they going to develop or are going to nurture this particular character? This character can only be acquired by looking at those who are in charge of this particular, for example, in a classroom setup, like those who are lecturers and training your trainees. You need to inculcate in this particular trainees good character, what we are calling values, so that when they get out of this field, we have health professionals who are ethical in their behavior and everything that they do. So this means that even as you prepare to move into receive the learners who will be undergone CBC, we expect that the inculcation of good character in these learners must be right from the day one you receive learners in your colleges. Because if we don't do that, then there will be a problem. And the problem that the Kenyan government had foreseen will have not been solved. So the disconnect between the values and what happens in the real world became a problem. And therefore, how do we solve it? We bring in the what? The character, by ensuring that we bring up the health professions who have good characters, who are able to live with the rest of the society. The third problem was the disconnect with the 21st century skills, which has been viewed as knowledge and skills, skill age that demands a new set of competencies. And how do we intend to solve this by the new education system? By making sure that the school system needs to develop Kenyans who can creatively solve problems. There is no employment in Kenya. It's a fact we all know because we live in this country. So how do we get to solve this? We are generating people who are creative. If you are going to train your health professionals, we must train health professionals who eventually will become creative, even the way they do their things. There are certain things that will not be taught, they will not be taught in the classroom. But out of the creativity, out of their own creativity, they will be able to solve a number of problems. So those three problems gave birth to the competency-based education. So we understand what the competence-based education generally wants to solve in this country. And therefore, at the topmost, we have the competency-based education. You have had people, at one point when this term, competency-based education, was talked about by the PS, the current PS, people are wondering, this CBC has changed again. Because all along we have been talking about CBC, CBC, CBC. CBC is the second pillar. After the competency-based education, it is implemented through what we call the CBC. And the CBC is what provides the prescribed curriculum. A curriculum which is standardized and what is expected of every learner in this republic to go through. So that is what the CBC, what we call the competency-based curriculum, which is developed by the Kenya KICD, Kenya Institute of Curriculum Development. Then on the right-hand side, we have what we call the competency-based learning. The competency-based learning is what is experienced, the curriculum experience in the classroom. That is what is learned whether intended or unintended. So this is what the classroom teacher passes on to the learners. So that now we have the curriculum being experienced by the learners. If, for example, you go through the teacher is going through the curriculum, and in that curriculum, there are certain what we call the learning experiences that have been prescribed that the learners must go through. Then we expect that as the teacher undertakes the learning process, or as he facilitates the learning process, we expect that the learners are taken through those learning experiences. Very important, because those learning experiences is what will give the learners hands-on activity so that we generate a learner who is creative. So that is what we'll give us what we are referring to as the experience curriculum in the classroom, or the competency-based learning. Then at the far end is now where we have the competency-based assessment. That's where the neck comes in. So at that point, we are given our main objective is to measure the learning outcomes. We must come up with assessment tools and methods that can help us assess whether the prescribed curriculum is the same as what is experienced in the classroom, depending on the learning outcome feedback that you shall get after administering assessment. So even the way we administer our assessment must also be different, so that we are able to assess the experienced curriculum and give feedback so that improvement can be done. We may not concentrate so much on this slide, but what we are saying is, under what we are now referring to the competence-based assessment, we are basically looking at a process of gathering information or evidence about achievement of the learning outcome. So when you are gathering evidence, if, for example, I've already introduced myself, and those who are here have understood that my name is Ouko Samuel. I work with Kenya National Examination Council. I come from Homa Bay County, specifically Suba sub-county. Then if I gave somebody a microphone and ask him, what information did you gather about this gentleman? And then you start saying, the gentleman standing here is John Okoth. He comes from Migori County, specifically Suna East. How will you feel? If you are to give somebody direction, and that's what you have gathered about myself, and you are telling somebody about the person who talked today, and you are describing me that way, it means that you have gathered wrong information. If you gather wrong information about a learner, what are the consequences? Wrong placement, wrong outcome. Are you getting the point? So that is why under the CBA, we are so much concerned about collecting credible information about a learner. This information, if you are to collect a credible information, then you must have a credible tool. Move to the next slide. You must have a credible tool. So that now we are saying that the spirit of CBA is to collect evidence from multiple sources to determine learners' potential. That is what the CBA is advocating for. In the process of gathering this information, we must have professionals, people who have integrity, to help us gather this information. And that's the message we are passing to the teachers in the classroom who are charged with the responsibility of gathering this information. Like those who have learners in under CBC. You are expecting that at the end of this year, there will be some transition taking place to senior school. And you expect that teachers must have gathered the correct information so that when you now go for guidance or for consultation with your teacher, your child's teacher, you will be able to they will be able to give you the correct information as far as that your learner or your child is concerned. And that is the spirit of the CBC. Gathering evidence from multiple sources so that you are able to give the correct feedback. Next slide. This is what we are under NEC, where we are using this as what we call assessment parameters. So before we conduct or we develop any kind of assessment, we normally ask ourselves, why are we assessing? Why are you assessing? That's the first question that we ask ourselves. Why are you assessing? If you have answered that question of why you want to conduct an assessment, whether it is a weekly test, whether it is a daily test, whether it is a term semester at the end of the semester test, whether it is a test at the end of a unit, you must ask yourself, why are you giving this particular test? Once you have answered that question of why you are giving that test, then you move to the next level and ask yourself, how am I going to do it? How am I going to conduct this particular test? Which the modes? You'll answer the question, the modes. Once you have decided the modes you want to use to conduct this test, then you now decide which tool will be appropriate for me to use to gather. Remember, we are gathering credible information and we are gathering evidence of achievement of learning outcome. So you must decide on a very good tool that will help you gather that evidence. Otherwise, if you pick a wrong tool, you'll get a wrong evidence and therefore wrong feedback. So at this stage, you must make a very clear decision, and you must be very clear in your mind that this is what I want to assess, and if I want to assess X, I must use Y to get the correct feedback. So you must make that decision carefully. And then you must also think, how am I going to report? After I've collected this evidence, how am I going to report? Am I going to report to a learner directly? After reporting to the learner, am I also expected to report to the management? So you must also think of how you are going to do the reporting. So those three areas will guide you when you are conducting your assessment. You must get the question why you are conducting that particular assessment. If you don't have an answer why you are conducting that assessment, don't give that assessment because it will not help. But once you have the answers for why you are doing it, then decide how am I going to do it and which tool am I going to use and how am I going to do a report. Because the report is what is going to provide the evidence. The tool is going to help you collect the evidence. So how is the CBA, the structured assessment under competency-based education? This is how we have structured our assessment under junior and primary. Under junior school, we are having grade 4, grade 5. What we are doing is that we are having both formative and summative assessments that we are conducting. We conduct formative and summative assessment. Formative assessments are conducted in grade 4, grade 5, grade 7, and grade 8. Then we collect formative feedback, summative feedback in grade 6 and grade 9. All the assessments that we conduct in right from grade 4 to grade 9, that is in primary and junior school, they all count at the final grading of the what? Of the learner. So the classroom, or what we call the school-based assessments, what we call the SBAs, are very key because most of them are practical and projects. We are trying to go that direction because we are trying to make these learners start learning to be hands-on, so that by the time they are getting to your colleges, they are people who know that learning must be practical in nature. They must be hands-on. That's why we have introduced the school-based, what we call the project and practicals, as early as grade 4. So this learner grows knowing that if meaningful learning takes place when I do it practically. So we are giving them an opportunity to do those things practically and manipulate figures, manipulate apparatus, and make decisions and conclusions at their level. You may look at the project given at grade 4 and you wonder what is the meaning of this. It looks like rubbish. Are you getting my point? We don't expect grade 4 to give a project that to a grade 4 that, in other words, each project must be as per the level of the learner. When you are up there where we are currently, you may look at a grade 4 project and you dismiss this. What is this? Rubbish. Is this what I can do? That is their level. As they move to the next level, the nature and the rigidity of the program, the projects and practicals, they become more demanding. By the time they are getting to your institutions, they will be more demanding because now they'll be duly dealing with human beings where errors are not tolerated. So that particular thinking must be, we must start inculcating it right from from primary school. Then at the back kidogo, you moved far. Apple. Then after that, we are saying that all those assessments, we are putting all of them, they're giving us 20%. The 20%, we move with it to grade to junior school. Then in junior school, again, we do school-based assessment, grade 8 and grade 7, which will give us another 20%. Then we put 20, and the 20 gives us 40%. So the assessment that they are waiting to do at the end of this year, that is in November, October, November, will only constitute 60%. Move to the next slide. Then at the senior school, this is the same will take place. We shall have this SBS in grade 10 and 11, which will give us 30%. And then grade 12, they will sit a summative assessment, which will give us 70%. Then we add 70 and 30 to give us 100%. So from senior school, then they will now transit and join your colleges. So move to the next slide. So that is what we are expecting at the end of the senior school. We are expecting them at grade 12. They will sit what we call the Kenya Certificate of Basic Education. And then from there, they will transit to the tertiary colleges. What we need to understand is that at that particular level, we shall also issue what we are referring to as learner exit profile. Learner exit profile will give count of the learner. It's an equivalent of what we used to give previously as the living certificate, but this is going to be a more detailed because it is going to give more information about learner, including the participation in community service. So that is going to be important as they join your team. So how are we grading them? Next slide. Just move to the next slide. That is for the stage-based pathway. For the stage-based pathway, we are having 50%. There's formative assessment, 50%, and the summative assessment taking 50%. So how are we going to grade these learners? We are going to give a report in terms of performance and achievement levels. Currently, we have been talking about meeting expectations, approaching expectations, and below expectations, right? You must have heard about those terminologies. So how are we going to do it now as they transit to your colleges? I know one of the things that you'll be asking yourself, how are you going to do admission? How are you going to do the admissions to these learners if we are not going to report using marks or grades? But I want to tell you that we shall be doing both quantitative and qualitative reporting. So if you look at this, for every performance level, there are 2 achievement levels. If it is below expectation, we shall have below expectation 1, 2. Same to exceeding expectation, exceeding expectation 1, and then 2. And then at that, we shall be giving them what we call the GPA points. So from there, given, depending on now, this cluster subject for each course, you'll be able to use the GPA points to know how to place your learners. Currently, for example, if a course that has been, currently you have been admitting, for example, in a certain particular course, you admit candidates with the D+. Where will that candidate fall? Where is it likely to fall? At least you can see, with this guidance, you'll be able to see how to work your way out on whom do you admit for which particular course. So that is what we intend to use at grade 9 and at grade 12 to grade our learners. So when we talk about meeting expectation, approaching expectation level 1, that is exactly what we shall mean. So we shall not be having a scenario where we now do the grade, the D+, the B+ that we had initially under 844 system. Next slide. So what are we doing currently in teacher education. I've decided to narrow down on teacher education because that's a professional course similar to what you do under health professions. So what are we doing under teacher education? Move. Under curriculum and pedagogy, these are the things that we are doing under teacher education. One, we have introduced what we are referring to the practicum. Practicum, initially it used to be teaching practice, which was being done in one term. Are we getting the point? This time around, we are now having assessment of the practicum done 4 times. The practicum is now what the teacher is going to do outside there. It gives the teacher the skills of what he's going to do as a teacher. So we are giving it a lot of prominence. And that's why we are conducting assessment of the practicum 4 times. There are 3 assessments which are conducted internally and 1 assessment which is conducted externally. So, and all the learners, trainees are assessed. There's no sampling that we want to sample 1, 2, 3, then we use that as the whole to represent the all other candidates like we used to do in the previous system. In this case, we are assessing each trainee individually. So with that practicum, we are giving it more weight, and therefore, so that we give the teacher enough time to practice. Other than that, there is what we call the structured mentorship. The way the teacher trainee goes to a school for a whole term to be mentored. Then another term to conduct the practicum. That's now the actual teaching. So the 1 term is for mentorship, where the teacher sees, the trainee looks at what goes on in a classroom setup, how are things managed, and then the trainee comes now to do the actual practice. And then in this teacher curriculum, we are also focusing so much on collaborative assessment. We give other trainees an opportunity to assess their colleagues. We also focus on portfolio assessment. The introduction of portfolio assessment is very important because portfolio assessment can act like a CV. Like in the case of the health professions, you need to look up your portfolio to talk on your behalf of what you can do or what you have done. So that you don't, when you go for an interview, you don't need to be explaining so much about yourself. What is it that you have done? Your portfolio, like the professor that has just gave the what? The keynote address. The portfolio, if you are given the portfolio professor and you are looking for somebody, do you still need to look for the professor again? You remember what the MPs told one of the MPs told those who are interviewing the late Professor George Magoha, when he was appointed the CS. One of the MPs said, if you passed, you vetted and approved Rashid Echesa with no certificate, then we have no business interviewing the professor. In other words, what we are saying, your portfolio should speak for yourself. And that's key. Very key in our assessment, the portfolio. It can be done, we give them an opportunity to make it electronic or physical portfolio. But that portfolio assessment is a key changer, game changer in a teacher education. Next slide, please. Then in terms of assessment and evaluation, we are putting equal emphasis on both formative and summative. We normally give them 50% formative, 50% summative. So all the practical, because formative normally is practical, hands-on assessment takes 50%, and then the final summative takes 50%. So that is a departure from the 70-30 that we used to have in the previous system. And then we also conduct annual school-based assessment in the colleges. Next slide. The other important part that we have introduced in teacher education is ICT integration. Currently in Kenya, teacher education is fully ICT from end to end. From developing the assessment tool to awarding of certificates. So that means, because remember when during the presentation, there's a lot of talks about ICT, right? So how do we ensure that you produce professionals who are ICT compliant? Those who are digitally literate. You must therefore you must purpose to include that particular ICT in the training process. And therefore, we have made it intentionally to ensure that all the teacher assessment is fully e-mode, no paperwork at any given stage. So that means we are saying that even our marking, the way we do the marking, we are anonymizing the marking process where the accessor or the examiner only sees the response. Only the response appears on the screen, and you mark that response without the name, without any form of identification. Those scores are coded. So when they are marking, they're just given the computers. Once you are done with one, you click next, another response comes, you click next, another response comes. So at the end of the day, we are trying to eliminate human error along the way, especially where subjectivity normally comes in when you know the person you are marking, the paper you are marking. And how are we dealing with AI? Those who want to download, there is responses from the internet. Of course, when we are doing the assessment, we normally use what we call the safe mode. Once you have opened the portal, your screen is shut. So nothing, you cannot browse, you cannot log out. Once you log out, you are logged out. So that is the system we are using. So that makes at least, but you know human beings, right? The way Kenyans are very high in IT, they can hack even a central bank. So what about an assessment portal? So we are saying that during marking, because the responses are automated, AI they can easily be detected because it is soft copy. You can easily tell this one is AI generated and then punished by canceling the awarding grade Y. So that is how we are dealing currently. We are dealing with AI issues, but we have gone. So what are the impact? There is improved transparency and fairness in marking and results processing, and there is real-time feedback faster, that is faster results processing, and improved ICT skills for both trainers and trainees. When we started, move to the next slide. When we started, we had a lot of problems. There were a lot of the teacher trainees, the colleges went everywhere in this republic to say that NEC is doing X and Y. We don't want this, but we decided to just keep quiet and give all those complaints a deaf ear and soldier on. Right now, only those who have refused to embrace ICT are those who are saying, me, I only have 1 year to go. So I can't start making my head start thinking about those things yet. I'm only 1 year to go. But otherwise, majority of our tutors in colleges are ICT gurus. They have learned. Those who are not able to type right now are able to type. They're able to do their work through ICT because they must make those trainees to be digitally literate. And that's what we do. So what are some of the challenges that we faced? One of the challenges we faced was large infrastructure. It requires large infrastructure, installation, and maintenance cost. So how did you go about it? The KPIL through MOE came in handy, and they built iHubs in all the public colleges. All the public colleges have iHubs with over 450 computers and laptops for each lecturer to help us do that. The other thing that we did, we made it mandatory for the trainees as an admission requirement to come with your laptop, whether it is Core i1, Core i2, you just come with your basic laptop. That has helped the colleges to reduce the maintenance cost, because how many times do we repair our labs, our laptops? Rarely. But those desktops, almost weekly, one has run down. So that has helped us to solve that problem so much. Then website congestion during summative assessments. So how are we solve this? We now, during assessment, we now go and put what we call the local servers. So they download the assessment, the local servers, and then they now work offline. Once they are done, they upload the whole process. So that has also helped us to solve the challenge of ICT. Next. So then the implementation and rollout. How did we go about it? One, we did what we call phased rollout. We started by just 2, we piloted with just 2 subjects, only 2. Then we moved on. And before we did full implementation, we just did a pilot with only two subjects. Then we were able to get feedback with so many challenges. We were able to address those challenges, and utilize the feedback that we got from the teachers, and then we were able to roll it out. What other thing did we do? We train up preparation. We trained all the tutors in colleges, and we took them through on how to access, how to download the assessment tools, how to go about it, how to assist the learner in case there's a problem during administration. So right now, we don't even need, our presence are not needed in those colleges. During summative assessment, they conduct those assessments even without any NEC officer going around. They have fully understood how this is supposed to be done. Then every time we are conducting a summative assessment, we run what we call mock assessment. We give the trainees an opportunity to do mock using the past papers. We just upload the past papers, they download, they try, they answer, before we now bring in the summative assessment. So this mock also helps them to familiarize themselves with the portal and feel comfortable, so that we don't end up assessing ICT skills instead of what you were supposed to assess. Then next slide. So what are the impacts? I said that the impact now, I may not be able to articulate how it can impact on your training as health professions, but from the presentation, you'll be able to pick what is it that we can do and what is it that can work for us. So one of the things that you look at is the emphasis on real-time, real-life application of skills. Assessment, like if you are now, how you are going to assess your trainees, more emphasis should be given on real time. If he's a nurse or she's a nurse, where should more emphasis be placed when you are assessing this learner? On the practical skills. What this particular trainee is going to do after training. That is what should be given more weight. That's why we have decided, instead of doing 30-70, we have given what the teacher is going to do more weight. Like in the practicum, the pass mark for practicum, the pass mark for practicum is 65%. If you don't get 65%, like this time, the other day, we were just doing the awards for the practicum, and we realized that almost 300 of the teacher trainees are going to be asked to repeat the practicum. So we are putting more emphasis on pedagogy, the skill. What are you going to do after the training? That is what should be given more weight. Then assessment, we need to align our assessment to 21st century skills so that we produce what we call the global citizens, especially the IT. In the morning, the presentation was talking about digitizing health services. You must have a digitally literate health professional to manage those particular programs. So that means ICT should actually be made one of the core units, as one of the core units during training, so that you give everybody an opportunity to practice and develop the ICT skills. Then we can also talk of integrate assessment of values as core component of student evaluation. Before you award that particular certificate to this professional, can we come up with a way of assessing the values? You might be a very good doctor, very good health professional, but if you lack values, you know what will happen. So we understand, we all live in this country. Sindio, you go to an hospital, you may get, you are down there, you have taken a patient, maybe suffering, has suffered from X or Y. The doctors are in a relaxed mode. Very relaxed. When I say they are used to that, I'm told that is how they normally say. That, this one is even better. This one is even better. Yesterday I saw worse than this. So just relax. Relax. Shida yako ni nini? The way my boy normally asks him, Daddy, shida yako wanga nini? It's a young boy, 4-year-old. So that the values. Even hata kama hii yangu ni kidogo sana, kuja tu nishughulikie. Tuko pamoja? Yes. So that is now, can you, as a profession, can we think of how we are going to assess the values? So that as we award that particular certificate, are we producing a professional who have character? Remember, those are our 3 C's. One of them was character. If you have a bad character, you'll make a bad doctor, even if you are the one who knows where the cure for which disease. You are the only one who has the cure, and you have bad character, your patients will not benefit, because you want people to come and sweet talk you. No. Character. Tuko pamoja. Then in the other one, authentic. I think that when you talk about authentic assessment, that's now the real life. If it is a nurse, let the assessment be done on the real hospital setup, the real one. So that when you are now awarding certificates, you are awarding certificates to a truly qualified professional who is going to make a difference outside there. Then adopt portfolio assessment, integrate ICT in assessment processes, and also enhance ICT skills of the staff, very critical. If you don't enhance the ICT skills of your staff, how do you expect your staff to pass the same to the trainees? Is it possible? It is not possible. You must have that skill first as the teacher or as the lecturer so that you are able to pass it on to the next person. So that is what we need to do. And then the last one there, include digital literacy as a core unit in the curriculum. And that is what we do at Kenya National Examination with regards to teacher education. Thank you so much for paying attention.
Thank you. Thank you so much, Samuel Ouma. We really appreciate. Let us give him another round of applause. Mr. Samuel Ouko, asante sana. We really, really appreciate. At this juncture, we would like to open the floor for questions and comments. Just have your hand up and you will get the mic and you can ask your question, make your comment. Yeah, we have a question. We have several questions. So we'll take the first three. We'll take the first three. Then our speaker will respond to the first three. Yes, welcome. Tell us your name and ask your question or make your comment.
Okay. Good afternoon. My name is Joseph Mwangi, Deputy Principal, Tana River Campus. Thank you, Mr. Oruko. Is it Ouko or Oruko? Ouko, eh? When you are presenting, I was asking to, I was having so many questions, but I will summarize this into three. There's something you said about character. CBC will foster character development. And I was wondering what it for has not done, because I remember when you were in primary school, you were learning about national values, symbols of national unity, national anthem, loyalty pledge, and such. So maybe you need to tell us more what is character, because does it mean that character is being a yes person or to be a praise and worship person? Because sometimes, even when you see doctors strike, not that they don't know people will die, but circumstances. I think you have to tell us on that. You said at the end of the certificate, the end of the education will get Kenya certificate of basic education. You'll get a certificate, a national report, and a runner's profile. Now I was wondering, was what I was not able to do in grade 1, itawekwa kwa karatasi. Because if I was not able to make a scarecrow, we need to now present when I've been searching for employment. Now I was wondering what I did in grade 2 to daycare, what that has to do with me. Then in the grading, in KMTC, we normally take the mini grade and the subject scores. So the mini grade, you have been given the matrix, but now the subject score. Thank you so much.
Thank you. Let us take the next question and we'll be brief. Rosemary, this end.
Good afternoon. I'm Meshak Shundu from Kombewa, KMTC. My concern is a bit personal. I have a 5-year-old daughter, and when we meet, I always think about our future. And the issue of CBC now always rings in my mind. So, Mr. Ouko, my concern is about the infrastructure, because we have so much disparity in Kenya that each and every day we see in the news, maybe in Baringo. Like the other day, there was a school in Baringo without even a desk. And we could be having another school in Nairobi, which is with a well and modern infrastructure. So the level of this, now that we are in the spirit of equity, I'm concerned about the infrastructure, the disparity, and again, we are assessing using the same tool and same factors. Please, you may clarify on it. And again, I think this is about, you are talking about the national values and the other leadership, the good governance. I think it is high time government should have what you call a deliberate investment. So that if you are talking about education, let's have education that is equal for all, education with the good infrastructure, so that you can be talking about equal education and education for all. Thank you.
Thank you. The last question.
Good afternoon. Yeah, my name is Ben Simiyu from Siaya. In KMTC, we value competence because ultimately what the person will be able to do is what the person becomes. Now, what I've seen in junior, did I go now called junior schools? Most of the junior schools, my question is almost like his. Most of the junior schools, we are worried of the preparation of the learners. Are they getting quality education at that level, given the inequities in infrastructure? If they are learning, say, science-oriented subjects, at that level, they are being introduced, I hope. Are we having a laboratory? Because most of those junior schools are just the primary schools which had the same facilities, and now they have been converted into what we now call the junior schools. We are worried on that pathway whether these learners are being prepared very well for them to to transit to senior school and then come to KMTC. Maybe you can shine some light on that. Thank you.
Okay, thank you. Thank you for the questions. And I'll now invite Mr. Samuel to respond. Welcome.
Thank you so much for the questions. At least where we are currently, the number of questions has been going down. Not because they are controlled to 3. Previously, when we started the CBC, you'll make a presentation, and then after that, it's like the whole hall wants to explode with the questions. I remember one time I was in Nandi County, and after we have done the presentation, one of the teachers said that we don't even know what we are talking about. We were seated there. We were 4 of us, one from the MOE, another one from the KICD, another guy from TSC, and myself from NEC. So he dismissed that these people who are seated here are all quacks. I'm not exaggerating. That is how it was put. Because we told them, just ask the question. We'll not take any offense. Because you are all learning, right? So eventually we talked. And first of all, of course, we told him that we are not quacks, first of all, because we told him that we are properly trained teachers with 11 years in a classroom teaching physics and mathematics. So we are not quacks. We started from there. So eventually we were able to understand each other. So I'm happy that the kind of questions, not just here alone, wherever we make presentations, where the questions are not controlled, they are normally coming down. So, but does not mean, I think one of the things that, if you look at my presentation, one of the things under ICT challenges, one of the mitigations, somewhere there I said, accepting that there are challenges. Accepting that there are challenges. Then you work around them. That is what has helped us, especially from the next side. We started this thing from scratch. We didn't know, nobody told us. We were just doing some of the benchmarking, desktop research, until we were able to see how best we can do this. So as we move along, everybody's worried, not just you, Mwalimu. Everybody's worried in the country of what is happening, but soon we shall get there. So somebody, Mr. Joseph is asking about character. What is it that has changed 844? Even currently, a very good example, sometimes when you build a house, and the house that you built in 1980, you may not continue staying in it, even if there's nothing wrong with it. You may want to improve the way you do things. When you go to the, when you are CEO, when a new CEO will come, you will want to change the sitting. There's nothing wrong with the way the current CEO is seated. But somebody, a new person coming in, you just want to twist it a little bit to feel better, right? So there's nothing wrong in changing from 844 to the current CBC. Otherwise, it's also a requirement that education should be reviewed after every 5 years. But currently, this one has taken how many years? 38 years. And that is why under competency-based assessment, I say that we administer 2 types of assessment, formative and summative. Formative assessment is supposed to help address or give the feedback to the learner as the learner progresses from year 1 all the way to grade 9. They're supposed to be continuous and constant feedback. And that's why the school-based assessments are there. So that we don't wait until this person is at grade 8 like currently, and then you get 250 marks or 210 marks. Then we declare you a failure. Our CEO normally says that, do you want to build an hospital or you want to build a mortuary? The current system, 844, was building a bigger mortuary. In this system, we are building a bigger hospital where people go for, once you get a feedback, you work on what you have understood or what the feedback is saying. So that as we progress, you are constantly under the watch of a doctor and you are given feedback. Rather than waiting up to the end and then we say that 38,000 learners in the country have gotten E, like this year, last year. 38,000 of the learners registered grade E. We are trying not to get to that direction. So that's why formative assessment will address your problem. So that even if the subject that you scored in grade 2, after you did assessment in grade 2, the teacher should have given you feedback at grade 2. And that's why we are talking about character. If we don't have teachers with characters, they will not bother to give you feedback even as a parent. But if you have a teacher who has character and values, they will be able to tell you exactly how your learner has done and what this learner requires is needed to do to improve to the next level. So this issue of character is not just for you health professional. It's also too much outside there in terms of even the integrity. Character even borders integrity in our examinations and assessment. You have seen sometimes the way we handle some teachers when they misbehave and go as per what is expected. What's not, they do things that are not expected of them during assessment. So that is basically how we are moving in that direction. Character. Whether you are a teacher, you must be a teacher of good character. If you are a teacher, if you are a learner, student, or your child is being taught by a teacher with no character, then you are doomed. And that's why we are saying this system, we want to produce teachers who will help us to inculcate that particular character into our learners. So the scores will still be taken care of because the feedback will be given by the teacher. Then, I didn't get the name, the second person, infrastructure in the country, equalizer. Here we are talking about equity. And then there's another infrastructure school down there without a locker, without what? Electricity, without a teacher. So how do we bring all this together? I remember our professor, the late Professor Magoa, said, you better have a student seated under a tree, but with the teacher in front of them as an instructor. Those who are seated here, me included, where you learned, how was the nature of that school? How many have been to Suba? Suba, we don't even have roads. So even the teachers who are going there, they get there and they say, hapa. No, we are going this other direction. So in other words, what I'm trying to say is, it is true that there are schools without proper infrastructure. It is also true that the government is doing a lot. We all live in this country. It is true that the government is also doing a lot to bring that. But we also know that it is not possible to bridge that gap overnight. Given those, whether you want to call them injustices that have been there for so long, it will take some time for all these schools to be brought to book. And that's why in our assessment for grade 9 this year, we are not going to have the practical where the learners are going to be considered to bring apparatus, Bunsen burner, a pipette, a burette somewhere there, because we are all aware that if we go that direction, then we shall disadvantage the learners in such schools without the laboratories. So we are alive to that. And that's why the integrated science, which is in grade junior school, will have a paper two, which is what we are referring to as a dry practical. You know what's called dry practical? You are given things, then you manipulate to bridge that gap at the assessment level. But that does not mean that these learners are not given opportunity to do practical. During school-based assessment, they do all sorts of practicals. So that is how we are going to take care of that. Otherwise, it will take time for the all schools to be at the same level. I think that question was also connected to Mr. Simiu's question about competencies, and that is getting worried about preparation of junior school. So government is doing a lot of effort, and as I've addressed the issue of laboratory, that is how, as the assessment body, we have tried to bridge that gap. Imagine that we had said we have asked those schools, buy 15 Bunsen burner, one Bunsen burner for every learner, 5 Z-watt. You know those apparatus, the glasses, the mirrors, the retort stands. It will be too expensive and it will not be doable. So we are alive to that, and that's why we are going that direction. Thank you.
Thank you. Thank you very much, Mr. Samuel. Another round of applause. Yes, at this juncture, I would like to call our Head of Department of Health Professions Education, Dr. Gulani Lewa, to lead us in appreciating Mr. Samuel.
Thank you, Dr. Maricela, and thank you to our speaker. Thank you, members, participants. I'm very delighted this afternoon from the discussion that Mr. Oko has given us, because in the Department of Health Professions Education, for us, we have been competence-based for quite some time. And those of us who went to college in the 90s will remember that GPA was a real thing, and it is coming back. So we really want to appreciate you that these things are coming back. When the 844 got momentum, and they are the ones who made the GPA to be taken away because they thought it was unfair. But now it is coming back through the CBC. So thank you very much. We also want to thank you, Mr. Oko, for enlightening us on this type of assessment, because in CBC, there will be no failing. I don't know whether you have realized. Each learner will have a pathway. So there will be no failing. If they can make a scarecrow, Mr. Joseph, they'll be allowed to follow that path and make a scarecrow and make it useful at some point. So portfolio again, I think for my colleagues from Health Professions Education, we really want to thank you. This is something that we have been singing, I think, for the last 10 years, that we need to adopt portfolio assessment even in KMTC. And there's been a lot of resistance. Now you can see they are bringing the portfolio from CBC. When they come to KMTC, they'll already be having the portfolio, and we shall have no option but to carry it on. So we really want to appreciate you. Thank you so much. I want to finish by saying that, and in the presence of our participants, particularly the principals here, we have been drumming up support for a clause to be included in the admissions letter for our learners to come with laptops. And it has met a lot of resistance, Mr. Oko. And they keep on saying, you know, we are a poor nation. Our learners will not be able to buy. Now, teacher trainees are buying. I'm not saying you tell them to buy, but thank you very much. I hope we are going to get this. And to appreciate him, I want us to appreciate him in the imaging way. And Madam Ko is here. You know, in imaging, literally called radiology, mambo ya X-ray. Before they take the X-ray, I don't know whether any of you has seen they run away to hide. And when they are going to hide, they usually say expose. Expose means there should be no one near the patient. So we are going to give you one big clap by exposing. For all these things you have enlightened us. So 1, 2, 3, 4, go. Thank you very much. And we want to give you a small token of appreciation from the organizing committee. And to do that, Principal Bungoma Campus, Madam Koi, kindly. Yeah, we expose. Thank you. Welcome, Mr. Oko.
No, for now, so that we don't get a lot of expression. Thank you so much.
Thank you so much.
Thank you so much, Dr. Lewa. Thank you so much once more to Mr. Samuel. We really, really appreciate. Now, colleagues, we are going to move to the next session of presentations of the research. And we are still in the sub-theme of health professions education. And I would like to confirm that the following presenters are in the room. Jenna Chola, yes. Jovin Baraza. Jovin Baraza? Okay. Yes. Richard Kolute, yes. Justus Muthe, yes. Francis Wambura. Francis Wambura. And Francis Muoki. Okay, thank you. So I'll ask kindly for the presenters to move and sit on the front seats here as the first presenter gets ready to make the presentation. We are also kindly requesting the team here that we be patient and we continue with the presentations so that when we finish with the presentations, then we can take a break for lunch and a break for the day, if that is okay. Yeah, thank you. So the first presenter, kindly get ready quickly. The IT team, you can get the first presentation on the screen as the other presenters move to the front seats. We shall also keep our questions Until all the presentations are done, then we shall ask to the various presenters. Okay. So the ICT team at the back, as soon as you're ready with the presentation, give us a signal so that we can begin. And as we wait for the presentation to come up, we continue to reflect upon our practice in health professions education. We have to challenge ourselves to think critically about our practice as teachers of health professionals. How do we improve on the quality? How do we maintain relevance? What do we do about having people who are prepared for the industry needs? What do we do about the emerging issues? New topics are coming on board, recognition of prior learning, modularization. We hope that a forum like this gives us a chance to converse on these issues. And at this juncture, I want to welcome our first presenter, Dr. Gulani Lewa, who will be presenting on influence of instructional methodology, training on teaching practices among lecturers at Kenya Medical Training College. Welcome, Dr. Lewa.
Thank you, Dr. Good afternoon. In the next few minutes, I will take you through a study that we did in college, influence of instructional methodology training on teaching practices among lecturers at KMTC. This is a research that, we did from the department. Those are the authors. I think there's one, there's one researcher who is missing there, Madam Lucy Kuria. That one we shall add. Next. Now, as a way of introduction, you know, in the realm of the Kenya education system, teachers are not required to have formal training qualifications when they are employed. You train as a doctor, you train as a nurse, and that is what we employ you as a teacher. So we all know that the fact that you are a good doctor, surgeon, nurse, clinical officer does not make you a good teacher. And teaching methodology, therefore, makes these people who are employed to teach get the skills that are required to impact knowledge and skills into their students. This is collaborated by Avals 2011, who argues that teaching methodology helps them acquire professional skills and improve their knowledge. Hong in 2017 noted that to enhance the 21st century skills and classroom management and promote professionalism in teaching, people have to be trained in teaching skills. And Rails et al. In 2019 noted that teaching methodology trainings motivates teachers to be committed and deliver content effectively. In KMTC, teaching methodology has been going on for over 20 years. And in the health professions department, we have been conducting a 2 weeks training program. By 2024, in the last 6 years, we had trained about 500 lecturers through this 2-week program. Next. What informed us to come with this research? Teacher professional training and quality and its quality influences students' performance. That is according to Laurisden. But teaching qualifications are not mandatory in the recruitment of lecturers. All of us, probably those who are recruited some time back, they were not required to have that teacher training certificate. So this leaves them to learn on the job. And according to Kushid et al., this gap has created a growing need within the medical education sector for instructional methodology training. This gap is what informed us to come up with our objectives. And the broad objective was to assess the influence of the teaching methodology trainings that we have been conducting over 2 weeks for our Kenya Medical Training College lecturers. What are our specific objectives? The media team there is not moving with me, but I'll try to move fast. To assess the lecturer's perception of instructional methodology training on teaching practices at Kenya Medical Training College, to establish the availability of resources for utilization of skills during the instructional methodology training, and to assess the application of competencies learned by the lecturers during instructional methodology training at KMTC. How did we get the sample size? Next slide. These objectives came up, made us get to the variables which we have shown there. And these objectives are independent variables on the left, dependent variables on the right, and the intervening variables are at the middle. Next. So we did a mixed triangulation study. We had key informant interviews, mainly principals and HODs. And then we had focused group discussion for students. And then we had, for our teachers, we had a semi-structured questionnaire. So we did a purposeful sampling for our key informants and focused group discussion. And then analysis was based on thematic areas that arose from the data. For our lecturers, we stratified them into different regions, and then from those regions, we had some specific colleges where we got now the teachers who had done the teaching methodologies, and those are the ones who are given the questionnaire. And then we analyzed using SPSS version 25. What were the results? On the lecturer's perception of training on teaching practices, 97.5% of the lecturers were satisfied with the training. 90% were willing to recommend the training to their colleagues. However, 67% of the lecturers felt that there was no sufficient follow-up after training. And the figures are there. Next. Now, instructional methodology training at KMTC led to observable pedagogical shifts among lecturers, particularly in the adoption of interactive techniques and educational technologies, thereby aligning local practices with international best practices in health education. So what we are saying here is that from the teaching methodology training, teachers had very observable behavior change in terms of the way they were interacting with the students and in terms of the way they were conducting their lectures. Next. On the availability of resources for utilization of the learned competencies, 89.8% agreed that the college has the materials, the teaching materials that are required. Teaching resources were at 64.5%, library resources at 63.5%. However, a big number of the population, about 90% of the lecturers, felt that laboratory practical equipments were inadequate. So 35%, this is what I was saying, 35.5% of lecturers reported not being sufficiently supported by the administration. And there were so many quotes from the key informant interviews, but one of the quotes from the key informant interviews was that we are a bit resource constrained and may not be able to provide the optimum numbers. Remember, this is from the principals. So they could not provide the optimal numbers for the lecturers to conduct the resources. On utilization of acquired competencies, most lecturers successfully integrated technology post-training, and the findings showed that 83.2% of respondents agreed, and this was collaborated by the focused group discussion that noted greater use of the learning management system platforms. The training contributed to increased digital literacy and adoption of e-learning modalities. One of the quotes from our students, and it was very interesting, these were third-year students who had seen diversity of teaching from first year to third year. Yeah, there's a big difference. For instance, there's move from hard copy to soft copy study materials, and with time, we've seen projections, embraced online teaching, offered learning materials, improved communication. So when you see this, you are like, they went for training. So the students were observing that previously they were not getting like handouts. Now when we ask, the teachers give. They were not using projectors. Now they are using. So probably they must have gone somewhere. So in summary, the findings from this study strongly suggest that the instructional methodology training delivered by KMTC has significantly influenced lecturers' pedagogical perceptions and instructional practices. Nearly all respondents expressed satisfaction with the training, and 88% reported applying the competencies acquired. Quantitative data showed that widespread adoption of interactive teaching methods, with 92.9% of lecturers indicating improved presentation and engagement techniques, and 83.2% successfully integrating technology into their teaching. These self-reported changes were collaborated by student focus group discussions, which highlighted enhanced classroom interaction and learner-centered approaches. However, the translation of training into sustained pedagogical change is moderated by structural constraints. Notably, 67% of the lecturers reported inadequate post-training support, and over 90% cited lack of laboratory and practical teaching resources. I'm happy the principals are here. These barriers, while not diminishing the initial influence of the training, constrain its full institutionalization. In conclusion, we are saying that the training has demonstratively shaped teaching practices and aligned them with contemporary instructional standards. Its long-term efficacy depends on continuous professional support and systemic investment in teaching infrastructure. Our recommendations are outlined there, and very basic recommendations that are can be put into practice. Thank you.
Thank you. Thank you very much, Dr. Lewa. Another round of applause. Yeah, so the comments and questions that we have for Dr. Lewa, they can be written down and they will be passed to the front as we prepare for the next presentations. So just write down your question if you have any and pass it to Dr. Lewa to process it, and then we shall have the questions responded to at the end of this session. So we are now going to welcome the next presenter, Jovin Baraza, who will make a presentation on the determinants of voluntary blood donation among medical students, a case study of Kenya Medical Training College, Kisii campus. Welcome, Jovin Baraza. Another round of applause. Jovin Baraza is one of our students. Welcome.
To our esteemed principals, lecturers, students, and all in attendance, good afternoon. Just a point of correction. I'm part of the team that Jovin Baraza is in, but my name is Ogutu Alice. So I drew the short straw to be the presenter. My team consists of Jovin Baraza, myself, and Joshua Okoth. As we've been told, I'm presenting on determinant of voluntary blood donation among medical students, and our study was based in Kisii campus. Voluntary blood donation is vital for maintaining blood supplies that cater for therapeutic healthcare, and World Health Organization promotes it as one of the safest and most sustainable sources of blood. However, despite awareness of this, donation rates remain very low, and this constituted part of the problem. The World Health Organization recommends that for every country, at least 1% of its population should cater for voluntary blood donation, which in Kenya translates to about 500,000 blood donations per year. But currently, this is not seen in our country. And in our medical fraternity, we saw that even in our campus, these rates are very low despite medical awareness and knowledge concerning blood donation guidelines. Objectives of our study, they included to assess how voluntary blood donation is among the medical students, to identify key barriers and motivations for donations, and to explore the knowledge and how it affects blood donation behavior. Our study, we used cross-sectional study within the campus, and we surveyed 243 students, selected through stratified random sampling, and the data was analyzed using statistics and correlation analysis. Looking at the patient's demographics, Kisii campus has 5 departments: medical laboratory, nursing, clinical medicine, biomedical engineering, orthopedics department, and HND, which constituted the others. So from our results, we saw that medical laboratory science department had the most participants, and this was attributed to blood transfusion science being part of the curriculum of their studies. The prevalence was at 29%. From the 243 samples population that we had, it revealed that the prevalence of blood donation was lower at 29%. And the finding highlights that the gap between knowledge and participation, because despite of the students having knowledge about blood donation, their participation in donation drives was low. The key barriers were attributed to workload, as it was seen, most students will attribute to being in clinical rotation areas or attending classes, and this affected their participation in the donation drives. And another barrier was health concerns. Most students will attribute that if after donating, they were worried they wouldn't be able to continue participating in their normal schedule. And others had fear for needles. Key motivations for the students who participated was altruism, that is helping to save the lives of other people. Concerning knowledge and behavior, 71% of the study population recommended that donation frequency was at 71%, while 87% knew of the donation guidelines by the Kenya National Blood Transfusion Services. This, however, gave us a negative correlation of negative 0.11, and this indicated that knowledge alone does not predict action. In our conclusion, despite high levels of knowledge, voluntary blood donation remains low among the medical students, and factors that are attributed to this, as we have discussed earlier on, the gender also played part, the year of study of the students, because most students who participated were not of the senior classes. We recommended that incorporating blood donation awareness into the curriculum. And for this, I am grateful that even my principal is around, and maybe he can help to drive this with the other campuses, that this can be incorporated into the curriculum to drive awareness among the students, and also to address the issue of workload. Maybe a day can be set that the students can fully participate in donation exercises, so that no one will be afraid that maybe they cannot be able to attend classes after donation. And addressing the barriers, the awareness will address the barriers, especially maybe these ones for needle phobia. Some are just afraid of how big the size of, maybe in the hospital they are used to the 23 gauge needles, which are quite tiny, but for the donation needle, the size is quite huge. So while having the awareness, this can be addressed so that most students can be able to participate in the donation exercises. And as the medical fraternity, we know where the shoe pinches. In hospitals, we know the shortage of blood. And if we are at the forefront of driving this, then we can be able to address the issue of blood shortage in our facilities and help save lives through blood transfusion therapy. Thank you so much for listening.
Thank you so much, Alice and team. We really appreciate that. Another round of applause. Thank you. Yes, so we want to move to the next presenter, and we are going to continue sharing the comments and the questions, pass them over so that we can collect them and address them at the end of the presentations. So we now want to welcome our next presenter, as we appreciate the presenters for really making it brief and succinct in the presentations. And the next presentation is on readiness for interprofessional education in pre-service training programs at Kenya Medical Training College. Students, faculty, and academic administrators' perspectives. This presentation shall be done by Richard Kolute. Welcome. Let us welcome him together. Thank you.
Our esteemed guests, online participants, physical participants present also here. The organizing committee, fellow colleagues, good afternoon. Good afternoon once again. I want to make this short presentation And before just talking about it, I wanted to say that this is one of the first collaborative kind of studies, I think, which we have undertaken, and it was taken by 5 people, each from different discipline. We had one from clinical medicine, one from nursing, another one from nutrition, myself from pharmacy, and we also included somebody from laboratory, not laboratory, but library. Interprofessional education, sometimes referred to as shared learning, which we abbreviated as IP, is a very important teaching and learning approach that is designed to prepare health professionals for collaborative practice. And collaborative practice is very important as it improves patient care and patient outcome. Currently, it is driven by the, sorry, this is not the, please, this is not the slide. This is not the slide. We had brought a different slide. This is not, it's not this one. There is another one. The one, that's not the slide, sorry. But generally what I wanted to say that it's a very important teaching and learning method or strategy, which is designed to prepare health professionals for collaborative practice. And collaborative practice is very important as it improves patient care and health outcome. What is this professional, interprofessional education? It is a learning where students from 2 or more disciplines come together, learn together for the purpose of facilitating effective collaboration and teamwork. And we find it incorporating it in pre-service program is an innovative approach to preparing our future health professionals for collaborative practice. And what we say that before it is introduced into curriculum, the readiness of the key stakeholders must be established. When you understand the readiness of the key stakeholders, you will know how much they are willing, and you can also identify factors that you need to address for its successful implementation. So the aim, and no such study has been conducted for pre-service programs at KMTC. And I want just to mention there that collaboration, interprofessional collaboration practice is the way. If we are talking of becoming a globally competitive thing, those are some of the competencies for 21st century. So the aim of this study was to assess the readiness of students, faculty, and academic administrators towards IP, and also identify the associated factors that can be addressed for its successful implementation. And the research method was simple descriptive cross-sectional survey, which was conducted in June, involving 4 pre-service programs, that is clinical medicine, nursing, nutrition, pharmacy, and they were from 10 campuses grouped under 5 regions. And the participants were, students were pre-service students from year 1 to year 3, their lecturers, and then academic administrators. Academic administrators here are the principals because these are the people who manage resources. And again, registrars, these are the people also who run most of the programs. So a total of 1435 students, 60 faculty, and 15 academic administrators were sampled. Next. The tool which we used consisted of 2 sections. One was demographic parameters, because demographic parameters determine willingness and readiness. 2, readiness for interprofessional learning scale, which we normally abbreviate as RILS. This is the scale which is normally used all over the world when you want to establish readiness before you start. And it can also be used for monitoring the progress of training. So the tool which was used consisted of 4 subscales, which are normally the areas of interest when we are looking at this. Teamwork and collaboration, 9 items. Negative professional identity, 3 items. Positive professional identity, 4 items. And roles and responsibilities, 17 to 19 items. So those are the areas which I think we normally look at. And then we use a Likert scale, a 5-point Likert scale, which can be used now for scoring. So when you score teamwork and collaboration, that is 45. Negative professional identity, 15. Then positive professional identity, 20. Then roles and responsibility, 15, totaling to 95. So when you score 95, that is the maximum. The lowest is 19. So that is just an error that should be the maximum is 95 and the lowest is 19. And then reliability of that thing must be considered. So what we did was, how did we collect that data? It was paper-based. And as we were doing paper-based kind of thing, ethical consideration was observed that before collection of the data or collection commenced, we gotten ethical approval from Moi Referral and Teaching Hospital, Ethics and Research Committee, and then ACOSTI provided permission to collect the data. So data analysis, again, we use both descriptive and inferential statistics. And here I wanted just to say that the parameters after scoring, we use what the scale, what was scored by each group compared with their demographic parameters to establish if there was any kind of association. Yes, next. Next. Those are the results. Faculty, 1322. Those who participated. That is students, faculty, 55 administrators for that. And those are the things. And the good thing which you can look at this, mean age of students, which now you can be talking about. We can be talking about mean age of a student in KMTC, can be talking about that. Mean age of faculty at that time can be that. And then administrators. And those are the demographic characteristics of the respondents. Next. When we calculated, we scored, you can see that teamwork and collaboration was over. So if you look at it, you total it, the overall score for students was 76.978. That is high level. Faculty, 78.49, which is high. Then administrators for 78.29, which is very high. So in other words, when you see here, it indicates they are willing, they know the benefits of that. Next. So here, this is a very important thing whereby now you take the demographic scores and use ANOVA to compare with the overall scores. And that will give you association. Is there any association between willingness and some of the factors? And what happens when it comes to this kind of education? Discipline variation is a very key thing. And age is also a very important thing, because when you find somebody, there is association between readiness and age. That means when you are going to pick on people, you must address the age aspect. And so those are just the things. So what we did, we look at the p-value for the purpose of that. And if you just look at, I think we don't have a pointer, we were operating at a statistical significance of less than 0.05. And if you look at that, you look at the discipline parameter you find it is 0.00. That is statistically significant. If you look at that one of the faculty, it is 0.0029 significant. Administrator, no. And then when you come to these others, those other parameters have no significance or are not associated with readiness. That means that when now you want to implement this kind of education, the only thing which you will be taking into consideration address that discipline difference. That discipline difference, if you address it, then implementation of that program will go smooth. Next. So what are the key findings? I think we have already looked at it. Students up, faculty up, academic administrators up. And I think I wanted just to mention a thing here because it is good to note that when it comes to readiness, the nutrition students, the scores, I think they were the highest score. And then followed by the pharmacy, I think, were the lower. Then when it comes to nursing, academics, pharmacy, I think range from 83 for that pharmacy to that. I think you can look at those values to show you who the range. Because at times when you look at the range, some people can score very much below. But if you look at this, the ranges were just very close. So that means there is no much deviation from the group. So key findings are two. One, the level of readiness is high among the faculty, students, and academic administrators. They are willing, they know the importance of this kind of training. Then number two, statistically significant differences was observed under discipline. Among that is, so students, the readiness is determined by discipline for students. And again, faculty, it is the same. But when it comes to academic administrators, the only area where there was, it governed readiness was professional qualifications. But for professional qualification, among the items, among the demographic factors that have been reported in the literature that affect this, I think it is above that. So I think those are the key findings. And then conclusion, we can simply say that good degree of readiness towards IP among the students, faculty, and academic administrators, that discipline differences need some kind of attention. So based on that, what do we say? One, shared learning or interprofessional education be incorporated in pre-service training programs. This will ensure that the students we graduate from here have got effective, collaborative competencies to meet the challenges that are now rampant in our health system. And to address the professional differences, discipline differences, a sensitization program for students and faculty on the importance of IP be undertaken. Because once you have done that, everything will move forward. Thank you for listening. Sorry for that mix-up.
Thank you. Thank you so much, Richard Kolute. Another round of applause for him. That presentation on interprofessional education, comments, questions, again, just write them on a piece of paper and they will get to the presenter and they will be addressed at the end of all the presentations under this sub-theme. We are continuing with the sub-theme on health professions education, and I now want to welcome our next presenter who will make a presentation on readiness and predictors for blended learning among students at KMTC Nairobi, Kenya. That is Justus Muthe. Let us hold our hands together and welcome him to the floor. Welcome.
Members present, researchers, and faculty, I want to invite you to this presentation on readiness and predator for blended learning among students at Kenya Medical Training College. These are collaborative research among the lecturers in KMTC. When we are talking about readiness, we are looking at the willingness to use the method, and predictors, we are looking at the factors that can predict or determine the future use of this method. So the others, as you can see, the PI is Justus, then we have Mwanza from Mwingi, Moki from Garissa, and Mombasa from Makindu. So background, blended learning is an hybrid method that involves interactive face-to-face together with the online learning platform, concurrently put together for the purposes of sharing the information. It is important to note that student readiness is critical for learning purposes, because whichever the strategy or approach we use, the delivery of the information is what matters a lot. On our problem statement, or what's motivated us, is one, during COVID period, education came to a standstill. And here we have KMTC, which was expected to play two important roles. Number one is to give out the health workforce to be able to tackle the pandemic. And number two, KMTC is a learning institution that was expected also to produce graduates. So the objective was to assess the readiness and the predator for blended learning among students. In our methodology, this is a proportionate sampling method, whereby we looked at the 6 regions of KMTC, from Nairobi region, Eastern Coasts, Nyanza, and Rift Valley. And we looked at descriptive cross-sectional method. 3 to 4 students were selected from the campuses. The main outcome measure was the readiness for utilization and predictor for blended learning among students at Kenya Medical Training College. So what were results, or what our finding? This is, I must say, this is one of the papers among the bigger study that we are able to conduct, that the 35% of students agreed they were able to use a computer, whereas 32 felt they have seen a computer, but they cannot be able to maneuver whatever information that is there. If we were able to compare with the result number 2 on the ability to surf or ability to search for information, that is also based on the ability to use whichever the method that I'm a platform for teaching, that is Google Class, Zoom, then we notice that 40% strongly agreed can be able to interact with the method and look for information, against the 36% that felt they needed assistance of that method. Now, looking at the point number 3, amongst point number 1 and 2, then only 60% felt they could be able to interact with both online lessons and physical classes. Slightly, you're too fast. So that tells us we have 40% of the students who are lost on these 2 methods. And given this is the current mode that we're using as KMTC, both face-to-face and online platform through ERP. Let's move forward a little bit. The chances of utilizing blended learning, which we have agreed it is the both approach of physical and face-to-face, was increased by readiness and ability to use technological gadgets among participants. So if the participant or the student was able to interact with the computer, to interact with the platform, then they were more likely to use both the physical learning lessons and the online lessons. Yeah. So put against the multiple logistic regression to try and see which factor was very important, then we were able to agree that the digital technology 2.5 times more likely to embrace blended learning compared to those who are not able to use the digital technology. Yeah. So what are we trying to say? If I'm oriented to using the technology, then I'm more able to use it for learning purposes compared to the person who has not interacted with that platform before. So what are the factors that we are able to identify that were affecting this learning? Number one is acceptance from the student themselves. Number two, access to technological infrastructure from where the classroom is being offered. Number two, the hinge and the he of study. On this one, then we are able to notice that first years are more likely to use the method because for them, they do not have a choice. But also third years were more also to use the method because of the time limit that to clear their studies compared to those who are within the second year and 2.1. Then the technological know-how. Then I have the machineries, or the campus have the computers and the internet. Then am I able to use them to be able to access the information? So what is our recommendation on this one? That KMTC, in collaboration with the parents or guardians, to ensure students have ICT resources from the time of admission of studies, and then online lessons to be offered concurrently with the face-to-face instructional methods. So thank you so much for listening to us.
Thank you. Well done. Thank you, Justus Muthe. Another round of applause for him. And once more, as we get ready for the last presentation, if you have comments or questions on that presentation on readiness for blended learning, kindly write them down and pass them over to the front. Now we have the last presentation on this sub-theme of health professions education, and that is a presentation on sexual and reproductive health services awareness, utilization, and attitude among students in Kenya Medical Training College, Mwingi campus. And this presentation shall be done by Francis Mwoki. Welcome, Francis.
Thank you to the organizing committee, all delegates in here, participants and presenters, all protocols observed. Good afternoon. My name is Francis Mwoki, and I'm presenting on sexual and reproductive health services utilization, awareness, and attitude. I think the team projecting so that we can flow together. Yeah, this was a team research. We were 4 others. I'm presenting on behalf of the team. As you can see, in the team we have Judith Mwanza from Mwingi campus, Rosalind Jiru from Mwingi campus, Jemima Kialo, currently in Mutomo campus, and myself in Garissa. Sexual and reproductive health services awareness, utilization, and attitude. These are very critical area, especially to the youth, the population that we are training in our campuses today. And the WHO defines this as a state of physical, emotional, mental, and social well-being in relation to sexuality. Other parameters can be held constant, but it becomes typical SRH when we talk about sexuality in this particular population subset. It's a very critical area, quite crucial to the well-being of adolescents and the youth, and also in the post-adolescent stage. If you look at this against the global statistics, due to challenges with access to these services, many have ended up procuring abortion, 41% of new HIV infections, and a high rate of early marriage, especially when there are pregnancies and sexually transmitted infections not left behind. In Africa, the population of young people infected with HIV, you can see 430,000 young people and over 2.6 million living with HIV. Now, in Kenya, most of the young people are aware about these services. However, the access and utilization varies because of what we are likely to see in the next slides. Now, the challenges with sexual reproductive health is increasing, is growing. And this particular population, you realize that some avoid just visiting to express a concern on their sexuality or a sexual reproductive health challenge. Most studies have indicated engage in early and unprotected sexual activity with still misconceptions on HIV/AIDS. And in KMTC, and in particular Mwingi campus where this study was conducted, at that time we had a growing number of students reporting pregnancies, dropping out of school, deferring studies, affecting their duration of stay, and general well-being plus academic performance. And due to the lack of existing data on the levels of awareness, utilization, and attitude, then we sought to carry out this study. To justify the study, truly we needed this information, and the study intended to generate credible information that would support the interventions from the findings that were realized. The objectives of this study included determining the level of awareness and utilization plus attitude, and focusing on these three. Then we also moved further to establish the influence of demographic variables on the utilization of the sexual and reproductive health services. On the conceptual framework, maybe you can move to the conceptual framework, that's where I am. Yes, you can see on the independent variables, there's demographic characteristics, the awareness, indicators that were used, utilization of the services, and aspects of attitude measurement. This was to give us the utilization of sexual and reproductive health services among the students. Briefly on the materials and methods that were used, this study was purely descriptive, cross-sectional, institution-based. And our study population was of students. We used a semi-structured questionnaire for data collection, and our analysis of the collected data was by use of descriptive statistics and aspects of SPSS, version 25. On the results, the demographics can see majority of our student population was between 18 and 22 years, 23 and 27 years, with a small population between 33 and slightly higher. Most of the study participants were females and were single, and majority of them were Christians. Considering their level of study or year of study, we had most of them who participated being in year 1 and a small proportion in year 4. This is when the nursing program was running for 3.5 years. On awareness, yes, we can see the levels, and most of them, 79%, indicated that they knew of family planning. A smaller proportion reported to be aware of the HIV testing and counseling, and 3% indicated safe sex. The next item is on the services that were utilized commonly. Information on counseling with a frequency of 32, that was giving us 18.3%. And the list was on services that were related to abortion, especially the post-abortion care, which was at 0.6%. On the attitude, from that table, you can see those who indicated that they would use ABC strategy in relationships were 106, giving us 60.9%. And those who indicated that they would test for STIs if they had unprotected sex were 115. Running through that table, you can see the list were those who thought SRH services at the campus were confidentially provided, 27.2%. With the influence of social demographics on utilization, on the age, those who are 33 years and above were 4. And the utilized were 4. Those who are not utilized were 2. There is an association of utilization with the age. And this would be coupled with the exposure, level of confidence, and most of that population, they are, you can see the marital status down there. Again, we had some level of statistical significance in religion, which was significant at the Christianity. Level of training gave us a p-value of 0.239. Marital status 0.016. On the conclusions from this study, awareness was relatively high, but still we have barriers to utilization of SRH services amongst our students. Some attached to religion, feeling of discomfort, or even stigma if they accessed, which was more on the male students. And there was an indication of inconvenient service hours and lack of privacy. And therefore, from the findings, we recommend that we approach this collaboratively as a college and see how we can have SRH services awareness programs so that when they are coming for these services, they don't feel like they are coming to expose themselves to the provider, who will now use the information to demean or make them feel stigmatized. And this would enhance the uptake of sexual and reproductive health services amongst the students. I wish, on behalf of my fellow authors, to acknowledge the participation and voluntary participation of all study participants, the research assistants who enabled us do the data collection with ease, the Mwingi campus community, because this is where the study was conducted, and KMTC for funding this study. Thank you so much.
Thank you so much, Francis Mwoki. Another round of applause. Yeah, so we have come to the end of the presentations under the sub-theme Health, Professions, Education. And we had asked for the questions to be passed forward to the presenters. And I have seen papers coming round, and I'm sure all the presenters already have received their questions, maybe for the last presenter. So I'm going to ask as more questions and comments come forward that the presenters prepare to respond, and they will only have a maximum of 2 minutes to respond. So you are going to process, look at the questions that you have, and respond on the key issues that have come up as you make your final submissions on the presentations. So as the presenters prepare, maybe we have a comment from the audience on any of the presentations or on the proceedings or on the discussions around health professions education. Okay, so if there is no comment or question, then I'll right away begin with the first presenter.
Thank you. I have several questions here, and I'll hope to spend those 2 minutes answering them. Number one, why are you happy with the principal's presence? Thank you. I'm happy because you are the custodians of the resources in the colleges. 90% of the lecturers are saying there are inadequate laboratory resources for teaching. There's no one else. It is up to you whether you get them from the CEO or you get them from donors. You are the ones in the campus. So I'm very happy. And this is collaborated by Kondo, who also did a study in 2020. He found the same thing. 4 years later, the same report. We are still in the same campuses. Tufanye kitu. Then, how did you measure the variables of teaching practices? I think if you have been following from the students' reports, this was observational from the students and the key informant interviews. They observed an obvious change from the teachers. So this could be maybe a self-reporting bias, but we were relying on the reports from the participants. So there was an obvious integration of technology and so on after they had been trained. How do the teaching practices compare among lecturers who have undergone the training and those who have not? This probably requires another research. Those who had not been trained were our exclusion. They were not part of our study. So we could not compare what they had done. But it is another opportunity for us to do another study. Lastly, did you do a comparative study of those trained and those not trained? I think the same thing. No, we did not compare because those who had not been trained were not given questionnaires. We did not interview them. And they were not part of the study in short. But I think this is a good thing. We already have over 400 lecturers who were recruited. They have not been trained. Maybe we can do a prospective study from now. We get data, and then once we train them, then we get data again. You have addressed theoretical training. What about practical training? I think that the training is both theoretical and practical. We are doing it online theoretically, but those who have attended, including those of you who are here, we do micro teaching, PPT presentation, and instructional material development preparation. Of course, this was not something that we went to class to observe because it would have been very expensive. Thank you.
Thank you. Thank you so much, Dr. Lewa, for those questions. And I'll now invite Alice to come and respond to any questions or comments on determinants of voluntary blood donation.
Thank you. On my part, I haven't received any questions. So I would like to give a comment on behalf of my team. I hope that as we have recommended that we could have institution-led blood donation exercises, that it will be implemented so that our campuses can be on the forefront in implementing blood donation so that we can help the medicine as a fraternity as a whole. Thank you.
Thank you for making that recommendation. Oh, okay. Yes. You can come forward and introduce yourselves. And the principal is joining them.
Thank you, Madam. Again, I'm Mogutu Alice. I'm a third-year student, Medical Laboratory Department from Kisii campus.
Good afternoon. My name is Baraza Jovin, a student, MLS 3.2, Kisii campus.
Good afternoon, everyone. Mr. Principal, you know my introduction, so allow me to use it today also. So to all protocols accord, my name is Okoth Joshua Kinda, the first of that name. A student from Medical Laboratory Sciences, KMTC, third year student, and a serious academic protuberant. Thank you.
Thank you very much.
Good evening. Anna Sabisa, research champion of the campus.
Thank you.
Good evening. Laban Makori, the supervisor for the program, the project today.
Thank you. I'm also Daniel Nyakundi, the principal of KMTC Kisii. I commend this group. They did very good work during our science week, and we were able to identify their work. So we encourage them, and I thank the Nairobi team for accepting their work for them to present here. Thank you very much.
Thank you very much. I must say that the review process of the abstracts was very rigorous, and we are glad that some of the students were able to make it to have their presentations here. So I'm going to call upon Richard Kolute if he has any questions and a comment in 2 minutes.
For giving me again an opportunity. I have one comment from a colleague, and he's saying this approach of learning is well developed at USIU. Well developed at USIU. I think that is true. And I want to just say, all right now, if you look at all the institutions that are training health professionals, especially at the degree level, or JQuat is coming up. They have done a similar research, but with them, they only focused on two. That is on one faculty. Then as when we were coming up with this project, we were told that now the current trend is you must involve the three key stakeholders, and you are emphasizing principles are key because they are the ones holding resources. So I think that's all right. And then the other question which has come along with it is, did the study consider various mode of implementation? Or we only restricted because we wanted to have it as a kind of baseline. So this is a room for, again, further research. So if you want to look at this area, now you can pick up with that tool and then add this one as another element to look at. It is all right. And I want just to say, this method, this type of learning, there are 4 key ways of implementing it. 1, e-learning. E-learning is the best, the ideal. Number 2 is simulation. Number 4, case studies. And then the other one, questions which open questions which students normally do when they are doing this work. So, and I think KMTC well placed. We have middle-level colleges in Malaysia. They're doing a lot of work, especially for this one, especially in this area. So it is a good ground for KMTC. And then finally, if I don't mention the names of the people who did a lot of work, it will be not good. I will start with Purity Nyambura, in charge of library portraits. That's where we did also the pilot studies. Then we have Caroline Owino, nursing department, Thika. And we have Didier, who I think did enormous work, and she was saying, I want to see that work approved before we do it. That is NACOSTI and the MTRH. And the MTRH, they did two things. One, scientific review, and then ethical part of it. So please, thank you, members, for giving me the time.
Thank you very much, Richard Kolute. And I now call upon Justus Muthe, the questions and your final comment in less than 2 minutes.
Thank you. I have 4 questions to address. Number 1 is, when did you collect the data? The data was collected from the 3rd quarter of October 2022 to 2023, the 2nd quarter. Yeah. So that is from October to June of 2023. So what were your objectives? We had 3 cutting objectives, only that we picked one. Number 1 was readiness and predictor for blended learning. The objective number 2 was perception of blended learning. And the final one, challenges of blended learning. Yeah. The next one is, what is the area for further studies in preparation with CBC for implementation? I like to pick from the previous presenter here is, how do we integrate ICT in medical training, especially artificial intelligence in simulating medical learning and medical case studies. So AI is the key thing for me here, and integrating ICT. Who is the implementer of blended learning, and how are they prepared on this from your study? So this would take me to the question, what was the objectives? Only that we did not cover this one on this paper, on the challenges from blended learning. The latest implementer here is the Kenya Med College, through our custodian of teaching and learning, our principals. And I thank KMTC because of 2 things, as we have seen. One is harmonized curriculum that we are trying to implement in each department. And then number 2, the infrastructure that required to implement blended learning because of online teaching. So what are we looking at here? The presence of strong internet connectivity in our campuses. And then number 2, the presence of the resources required. That is the projectors, the laptops, and the computer lab for those students who cannot be able to access those materials. I'll pick again harmonized curriculum because of face-to-face guided teaching, because of interaction, where the student can interact with the lecturers that are presenting online. Thank you. So before I leave, I would also wish to thank the KMTC Board of Management for sponsoring this project, because it was funded by KMTC. Thank you.
Thank you very much, Justus Muthe. And last but not least, I want to welcome Francis Muoki to respond to the questions that he has and give us his closing remarks.
Thank you. I go straight to the questions. When did you collect this data? This study was run between 2019 and June 2022. So the data was collected in August 2021. Analysis followed, and the whole research process was concluded in June 2022. It's a question I expected because a lot has happened in sexual and reproductive health issues, which maybe most of us have had access to. However, even up to as recent as yesterday, we are still having challenges with sexual and reproductive health services amongst college and university students. At this time, when we were conceptualizing the idea, the only study that was available was a study that had been conducted in 2018 in Mount Kenya University. So the search of literature and many other aspects was really challenging, but as we moved on, we were able to do the study conclusively. How can KMTC use these findings? Yeah, to discuss with the individual campus management so that students can have access to sexual and reproductive health services in a manner that they will feel like they are confiding and the information will not be used maybe to judge them or paint them differently, because we know this is a very sensitive topic. What is the area of further research in this area? So the areas are many, but of priority, I would say the risky sexual behaviors. The risky sexual behaviors, because we have even seen in the findings, the knowledge is there, but utilization is very low. Statistical test, yes. I think in the first table we had in descriptive statistics, and we also used chi-square. The last one, what was your independent variable? If you look at the three parameters that I've presented on, they appear to be determinants of utilization of sexual and reproductive health services. And therefore that would be added to the conceptual framework. Thank you.
Thank you so much, Francis. And that marks the end of this session, on this sub-theme on health professions, education. We really want to extend a hand of gratitude to all the participants and all the people in this room. We really appreciate your presence here, your patience. And at this juncture, another round of applause for all the presenters. And another round of applause for the rapporteuring team. And another round of applause for the ICT team that is at the back. And another round of applause for the convening team that is at the front. And a big round of applause for all the participants in the hall. We really want to appreciate that it's not really possible to plan and hold a conference if there is no audience to listen to the proceedings of that conference. And we also want to extend a round of applause to the listeners who are online. And we really do hope that the presentations and the discussions that have gone on in this session have at least stimulated our thoughts, have at least challenged us in one way or the other, or at least introduced something that we did not know. And I hope that as we move forward as an institution, this is not going to mark the end of this discourse, but just the beginning. And we hope that as we go forward, we are going to look at more areas that we can engage in this discussion. So as we prepare to go for our very late lunch, I now want to welcome the chairperson of the conference committee, who is none other than Dr. John Antsetse Aswani. Welcome.
Thank you. Did you appreciate the chair of the session? A round of applause for her. Thank you. Yes, she has invited us for lunch. And because time is quite spent, I do not have many words. Just to appreciate your patience with us despite the many disruptions. I want to believe that tomorrow will be a better day. And I know there may be some questions about Friday. We will possibly have some answers tomorrow morning. And so as we close, may I request Principal Karen just to give us a word of prayer, and then we proceed to have our lunch, and then we can disperse. Thank you.
Thank you. Have you enjoyed? We'll make it better. Let's pray. Father, we are so grateful. You remain our Father and our God. You have been, Jehovah, the one who has been with us since morning when we started. And now, Jehovah, we are bringing this to conclusion. Jehovah, we can only say thank you, thank you, thank you. Thank you for the presenters. Thank you for the inauguration. Thank you for the chief guests, our CES. Thank you for all the presenters. Thank you for also the listeners online and the participants physical here. We are very grateful, Jehovah. We can only say glory and honor comes back to you, Jehovah. Thank you for everything. And we ask your presence to be with us even as we part to go to our places of stay. And as we prepare to come tomorrow, Jehovah, bring us home here safely. And oh God of glory, help us to achieve our objectives. We thank you and we bless you. Thank you for the meals that you have given us. We receive with thanks. And as we fellowship over them or over it, Jehovah God, we pray that your presence be with us and go with us. In Jesus' name, amen.
So lunch is served at the same tent behind the hall, and welcome. And see you tomorrow at 8:30 a.m. for the next set of presentations.